moderated by Dr. Robert Nan. So please sit. David? Oh, sorry. All right, sorry. So David will moderate this one.
Okay. I will move straight ahead. Dr. Mahmoud Fauzi will talk about evolution of cleft palate repair. Thank you.
Thank you, Dr. Chang. My name is Mahmoud Fauzi al-Bastar. I'm a professor of otolaryngology at Cairo University. And we've been
Guys,
working...
attention to the speakers, please. We've commenced now with our session. So could everyone please give attention to the speaker? Thank you.
My presentation is about the evolution of cleft palate repair. And it's kind of trying to have the bird's eye view on how the procedures evolved over time in an attempt to make it clear for, especially for my junior colleagues who are just starting to expand their horizon and see the target clearly. I would like to welcome all our international friends and guests, Dr. Mann, Dr. Chang, Dr. Russell, Adam, everybody. We are really happy to have them always here and wish we can see them frequently. I personally enjoyed their presentations in the first and the lip session. It was magnificent. I'd like to thank my friend Mamdouh as well. It's always a pleasure to have me involved in these activities. Mamdouh is a very close friend. We've been working together since the early 90s when we came back from the United States. Okay, now as a concept, I believe that the surgery for cleft palate, the concept is changing from thinking about only a structural defect more towards the function, but in a static way, thinking about it in a static way. And the third stage is thinking about the function in a more dynamic way. Let me just start from the first item, which is the structure. This goes back as early in the 19th century, where I believe that surgeons looked at the cleft as a wide gap or a wide defect that needs to be closed. And the principle of closing this wide gap in something like the palate is making relaxing incisions and bringing the flaps together. Maybe we see that quite reasonable now, doable, but I believe in the 1900s and the 1800s, this was kind of a milestone, a kind of a invention that deserves mention. And in this way, you get two bipedicled flaps, bring them together, and I guess the credit goes to von Langenbeck. I'm not sure, I tried to exert some effort getting who did what, but I'm sure I have some mistakes. I missed some names. Maybe the experts here can correct me later on. So the principle of von Langenbeck is that when you get a wide gap like this and do relaxing incisions laterally, and then you dissect the mucoperiosteal flaps and bringing them together in two layers, you can close this gap. This is how they looked at the problem, is that it's a structural problem, and the answer is just do the relaxation incisions or relaxing incisions and put them together. And of course, there might be some tension even with the relaxation incision, so people started thinking about the pterygoid hamulus as a tethering force, and then the space on the lateral aspect of the palate was described as the space of Ernst, who I think started concentrating this space and how can you obtain freedom at this area, release all the forces that hold the palate from getting from lateral to medial and moves and closes the gap. So again, this is looking at the problem as a gap. only a structure from the structure point of view that I need to get it closed and that's it. That's the first circle. But again, this dates back in the 19th century. So I do not think that this should be our problem now. Just to close the gap, apply the relaxic incisions, obtain a tension-free closure, and that's it. Because if you just do that, probably you will end up with a poor functional outcome. You are happy that you closed the gap. It is going to heal together, but this boy, when he grows up several years later, his speech machine, as Dr. Mann said, I like the expression, the speech machine is not working properly. And then surgeons started to think about this target, that why we did the difficult part of it by bringing the flaps together, but now he cannot speak properly. So they started to think about the function. And I guess when they first started thinking about it is that they saw that the repaired palates are short, cannot reach the posterior pharyngeal wall. So they thought in a static way, maybe the function is corrected if I make a longer palate. And this led to the second circle of concept, which is I don't need only to close the gap, but I need to produce a longer palate. Okay, this, I think it goes back to the 19th, it's 1 century further, 1930s. And what are we going to do with the short palates, and how are we going to lengthen this palate? I guess the answer was in a geometrical rule that is used in plastic surgery, which is the VY, not the VYZ, only the VY. This started as the VY advancement. And it's a kind of a geometrical tool to make a scar longer, or makes the palate longer. And this was the first step in getting what we know as the pushback. And I guess the credit goes back to Vaux, Wardell, Kilner. This is a picture of Victor Vaux I got on the net in the 1930s. And the idea was, instead of doing the classic Langenbeck and having a bipedical flap, they made the incisions along the premaxilla and they push the two tips together in order to elongate the palate. And these 2 points go back here, and therefore the palate goes a little bit backwards. So this way you can lengthen the palate. And again, at this point, I believe that they were thinking that we not only need to close it, but we need to get a longer. But again, it's in a static way. Nobody is concerned about movement so far. Again, some modifications I found, like Dr. Ruding, by obtaining complete release of the muscle from the hard palate. It's all modifications to make the palate longer. That's it. To make the palate close and long. Intact and long. So maybe if we can even release the muscle and even the mucosa of the hard palate, we can reach a longer palate. So again, back to the evolution of concept, we started with structure, and now we're talking about function in a static way, that if I lengthen the palate, I will reach what I want. And I convert the bipedicle of von Langenbeck into a unipedicle, and I use the geometrical tool, which is the VY advancement. However, I am borrowing mucosa from the hard palate and pushing it back to the hard palate, to the soft palate. Again, this ended up with a poor functional outcome. And of course, as Dr. Shang said, this is the only technique that I think is quite clear that it affects the growth of the palate. So again, the outcome was not satisfactory. I don't think anybody's using the pushback again at the time being. So the third stage, the third circle, is that I need to close this wide gap. I need to have a long palate, but the thing is, there is some dynamic function about it. Thinking about that there is a muscle, which is the levator palati muscle. This muscle is very important in having the action, pulling up the soft palate against the posterior pharyngeal wall and getting the speech engine to work again. So we started thinking about closing the palate, making it a little bit longer, and restoring the levator palati sling again. I guess this started, this concept started in the 1960s when they had closed long palates, but they are immobile. They are not moving properly. So thinking about restoring the muscle sling again. And here, I think it started with the two-flap palatoplasty with intravelar veloplasty. And I believe the credit goes to Bardak he's from Poland, I think, Adam, right?
Yes.
Yeah. Yes, he's Polish, right? He lived in Poland, or I think he lived. He lived in. He moved to the U.S. Okay, to Iowa. Yeah. Iowa means yes in Arabic. Okay, so this is how the two-flap palatoplasty is made, with the moving the muscles here to bring them in the midline in order to restore the velopharyngeal ring and the levator ring. I consider that this is the simple way to close the muscles. Now, I think one of the game-changing was what was introduced by Leonard Furlow in the 1980s, when he started using another way of geometrical tool instead of the VY and all this. He started thinking about the Z-plasty, but you cannot make the whole palate like in one Z. You are going to destroy on one side, the muscle is going to be destroyed. So the idea in having the Z-plasty in general is to not only to bring these two spots away, but to reorient the muscles as well, or the scar in general. So that's how he designed his flaps. We have several flaps actually. Not sure why it's not working. The first flap is the right anteriorly based oral. I'm not gonna take time describing the exact technique, and then the left posteriorly based oral myomucosal flap, and then cutting through the right side again into a right posteriorly based nasal myomucosal flap, and then lastly the left anteriorly based nasal mucosal flap. And I just want to stop here and mention our first experience with Furlow, me and Mamdouh. That was in our children's hospital. We read it very, very meticulously, and we watched the video for Dr. Furlow, and we decided to do one of that. And inside the operating room, of course, when you see all these flaps cut, you feel that there is no way that this palate is going to come together. That's our first experience. And he used to make fun of me because I insisted to keep trying on the Furlow. And now he's using it all the time, right? So you owe some credit to me. Okay. So, and then when these things are closed, of course, at this time, I'm an ENT surgeon. When you break all these four flaps, you can see the adenoids. We never saw the adenoids. You only see it on the x-rays. But now you can see it that clearly, and your heart is beating, because at that time, it's very, very hard to imagine that these all four flaps are coming together. And then you start by sewing the nasal Z flap and then overlap so that you get the muscles, the posterior flaps, both at the nasal level and the oral level. So this is the double opposing Z-plasty of Furlow in the 1980s. And then we had the chance to listen to Dr. Sommerlath. He came and he described his radical muscle repair. He's using the operating microscope. The idea is that sometimes when you look at the muscles from the oral side, the surgical view, you think that this muscle is the levator. The levator is towards the nasal side. So what you see is probably the palatoglossus and the palatopharyngeus muscles. Dr. Sommerlath showed us that using the microscope, you can get to see exactly, this is a drawing in his article, like the levator itself. This red thing is the levator itself, and take sutures in it. So it's a way of a radical repair, definitive, and using magnification of the microscope. I had no problem with using the microscope, again, being an ENT surgeon, but we all have questions, and maybe we were talking yesterday about that. So, but what I want to say is that there is evolution. people thinking how to restore the function in a dynamic way, not only the static way. And now we are beyond that. We have my friends, Dr. Abul Hassan and Dr. Man, they are adding a new thing, which is adding tissues to the palate. That the palate is not only having, I'm going to repeat, it's coming back. But anyway, you have to add the buccinator flaps as well to the tissues. We are here to discuss, and I was very happy listening to people having conflicts in the technique in the lip, and of course we expect that in the palate as well. But again, the idea is people are all the time expanding the concept because the target is not to close the gap. And unfortunately, I know a lot of surgeons who still are locked in the first string, that they just need it to be closed and that's it. No, see, look at when he starts talking, look at the speech engine. That's the final thing that we need to know. So going back, just to wrap things out, from Langenbeck, who introduced the releasing incisions, into Vaux, who started to push back the palate, into Bardach in Poland, who started thinking about the two flaps, into Furlow in the 1980s, who changed the game by doing the double opposing Z+, they maybe Sommerlad by using the microscope, and then our in-here friends like Dr. Aman and Mamdouh Abul Hassan, they are adding tissues that we're going to listen to that right now. But I mean, there is ongoing process in trying to think about the evolution from just simply structure into a static function into more of a dynamic function. This is the difficult part of it. Thank you very much for your attention.
Thank you, Mahmoud. That was a superb summary of the evolution of cleft palate and a reminder of the function and the reason why we want to close the palate. Great pleasure now to introduce Bob Mann again. And as Mahmoud has very eloquently provided us, I think Bob is really challenging our concept of how to close the cleft palate. And he's going to tell us more about his anatomic restoration philosophy.
Thank you, David. Yeah, David was commenting on the people that you have had the pleasure to mentor with, and just watching Mahmoud's evolution. Kilner trained Desmond Kernahan, who was one of my mentors, and so maybe that's why I'm very interested in growth, because Desmond Kernahan was an early bone grafter. We were doing our bone grafts at 6 months of age. That turned out to be not the best. And then Wardell Kilner, maybe not the best. So I'm very interested in the growth of the kids. All right, there we go. Okay. Well, thank you again for the opportunity to be here today. It's been great to have the wonderful parts of the conversations that we get to have in the breaks, and I'm sure Percy and David are having a great time with that as well. So let's get started. No disclosures. So the anatomic cleft restoration philosophy for me, as I started to think about what was happening, is a fusion of modern embryology and the fundamental reconstructive principles that I originally was calling the buckle flap approach. You go to Texas, they call me Buckle Bob because I do everything with a buckle flap. It's not all about the buckle flap. I think it's a big, big tool, but it's about what we're going to do with it. It wasn't until I met Michael Karstens, who is a plastic surgeon, and he has a bilateral cleft lip and palate. And he got very interested in embryology and looked at all of the past embryologies, the modern embryologies, and he's just finishing a very large book that has a lot of information in it. And I sat with him for hours as I learned more and more about what the cleft defect really is. And like we said before, it's a malformation. The pictures before were the lip. Here are the palate. You can see that we're missing tissue, and that it's a palate defect of an area of missing parts. As a reconstructive surgeon, if we think about it that way, it makes it suddenly easier. Because if we think about it as an area we have to reduce tension, we all have our own different tension measure in our own fingers. But if we think about it as we're missing parts, that tibia fracture is missing a bone, we have to replace it. That cancer took away part of the body, we have to reconstruct it, we have to replace it. And that's the concept that I was really embracing as I was going forward after talking with Michael and have gone forward to now calling it a different philosophy. The other part is the deformation process. We talked a little bit about it in the lip, and it's easy to see there. But in the palate, you can see it as well, as the muscles are in the wrong positions. And it affects the growth and affects the dynamics. I think that David and Percy were both talking about the impact and the hypoplasia of those muscles because they're not working normally. So in the child, you're dealing mostly with the malformation and what its impact is. So that's a piece you need to replace. But with the adult, you see these massive openings in the maxilla, but percentage-wise, the soft palate is really short. And that's partly due to the hypoplasia, the muscles not working, and partly due to the fact when they are working, they're restricting the growth from occurring. So that has to be addressed as well. So it's an entirely different set of complex issues that you have to reconstruct. So that's what modern embryology tells us. I'm going backwards. And sometimes we do that. There we go. I'm circling, and I'm not sure exactly why that's happening. Maybe I can do this. All right. So the four critical steps, again, are nose, speech engine, lip, and dental facial arch. And for me, then, the concepts within the anatomic cleft restoration philosophy are patient-specific care. So if that guy's hit by a truck, this person has a cancer, they're missing parts, but you look at them differently. And so we have to look at each child differently. Restore the missing tissue within the confines of present-day medicine. That's why I say the buccal flap is great. Let's find some other ways to replace tissue that's meaningful. Reduce scarring. We've talked a ton about scarring today. It's critical because everybody has a different scar load that they can handle. If you've got the person who's bulletproof, we all look great as surgeons. I want to treat the person who is a bad scar former and get a good result for him. We can't replace everything, so we must protect what we can't replace. The buccinator, or what I call the buccal flap, has been the workhorse for me because it replaces so many things, but it can't replace the muscles. So in '85, I called it the buccal flap approach at that time. I waited for many, many years, about 25 years. And we published this in 2017, 505 consecutive cases. And this is including syndromes. 6.7% was our need for speech surgeries. And our normal resonance was then attained 93% of the time. In the back part of that article was something that I was actually most intrigued by. When the work was done and we ran the numbers, we looked at a internal review looking at the small VO1s and the small VO2s and compared to the large VO2 3s and 4s. Those are the ones we all struggle with. We do pretty well with the small ones. And in the small ones, I was using Z-plasties, so that's still what I do. And we compared that group to the larger group. And sure enough, it was just a little bit different, but statistically it was the same across the board, getting the same resonance. But when we took the syndrome out, so we take the hypotonic kids out, and suddenly the statistics were the same across the board, but actually percentage-wise, we were getting better results in kids who heretofore were getting worse results than the kids who had the small clefts. And to me, that was one of the indicators for me that maybe I should be adding even more tissue. That's just my thought. Everybody could look at it a different way, maybe. So we're just finishing up looking at 662 patients in this time frame. And looking at the VO 3s and 4s, I had 164 of them with greater than 17-year follow-up. And we looked at needs for jaw surgery that was tabulated. And the results really in my era with the von Langenbach was about a little better than the literature for what's going on now, but the speech was terrible, and that's been well documented. The Jackson is Ian Jackson, an amazing individual we lost a little while ago, another great mentor to me. I got to watch him every time I go to the Mayo Clinic and visit my grandparents. And we got better speech with that, but still not great. But the growth wasn't very good in those kids for me. And then I started doing my hybrid repairs. So I'm doing Z-plasties and buccal flaps. Now remember, these are just Vo 3s and 4s. By the time I started in '85, the Vo 1s and 2s, Z-plasties and buccal flaps, that was it all the way. But because of the collapsing arch, it took me longer to figure out what to do with it. And so I was doing gingival periosteoplasties, relaxing incisions, unlined vomer flaps. I was doing everything with this group. And but I watched them grow. My speech got better, but I was still not getting great speech results or growth results. It wasn't until I kind of restricted everything from the group and said no relaxing incisions, no gingival periosteoplasties, early bone grafts, and vomer flaps. Part might be unlined if your buccal flap doesn't reach all the way, but it's very minimal. And suddenly I got better function in both areas in a dramatic way. And that just told me if once you get to, quote, close to normal, a lot of things improve. If your face is not constricted, suddenly your tongue position is better and your speech is better. Your speech pathologists love that. If you don't have restricted airways, suddenly your airflow dynamics is better and your speech and your function and facial growth occur. And we all kind of knew that, but to me, I was actually seeing that in this result. So then we looked at no surgery required, because that's, for me, one of the gold standards. If I can do a palate surgery and a lip surgery, and I don't have to do jaw surgery and I don't have to do speech surgery, that's really nice. So in my traditional, I didn't succeed very much in that, a little better in the Jacksons, a little better in the hybrids. But once I got to this other, I'm not sure what happened there. Once I got to this other, I'm 83% of the time, I don't need either speech or jaw surgery in the Vo 3s and 4s. So traditional literature, it's about 50% for jaw surgery, and I'm about 9.4% in the more severes. So now we look at soft palate, because we looked at kind of growth in that area. But what about the soft palate? Dr. Perry from East Carolina University, she's looked at some of the traditional repairs and noticed that there was a statistical difference in velar length, velar thickness, pharyngeal depth. And other studies have shown that the velum is shorter in the traditional. So we decided to put together a study, and I random just chose the kids during COVID, whoever could get in to get the MRI, and Vo 3s and 4s, average age 23, they had to be at least over 18. And we looked at these soft tissue measurements: velar thickness, length, levator palatini length, portal depth, effective velar length. I'll talk about each one separately. So when we looked at these compared to our age-matched normal patients without clefts, they statistically were the same in velar thickness, velar length, levator palatini length, and transverse positioning, and portal depth. What's portal depth? That's the measure from the posterior hard palate to the adenoid pad or the posterior pharyngeal wall. And this was normal compared to the normal kids. It was the same. Well, that's important because that tells you that your airway is about the same as normal and your face is right in the right spot as well. We then looked at effective velar length. This was an important one for me to look at, and this was statistically different. It was statistically different because many, many years ago, I would, in my mind, think if we're missing tissue, we're also missing muscle. We can't replace muscle. How do we make it effective? Well, if I don't have a lot of muscle and I'm not real strong, I got to get in the best mechanical advantage, and that was move myself back to get that muscle far back as possible to that pharyngeal wall. So when I'm putting in buccal flaps, I'm putting in as many. They say, how much to put in? I say, I'm going to put in as much as I can because I want it in the back. So this is effectively what I was doing in my mind is improving that area. But what happens if you're not adding tissue and you have a tissue deficiency and you put it together and there's normal growth? You have a short palate. So we've traditionally been doing pharyngeal flaps, excuse me. But we also have this unintended consequence of retrusion. Well, in those kids, they actually have pretty good speech because their soft palate deficiency hasn't been revealed. But for me, I was thinking, I'm missing tissue. I've got to replace it. So I'm going to replace the anterior soft palate, but I'm actually going to augment more of it to get that muscle back in that back place. And that's, in fact, what we saw. The effective velar length was statistically different, longer in the cleft palate patients. The effective velar ratio is the effective velar length divided by the portal depth. Well, you'd think it would be different, and in fact it was compared to our 15 controls. But in Dr. Perry's other larger database, this group still fell within the normal range, which means we were still in the normal range as a good indicator of velar VP closure in AP direction, and supports that the levator was adequately positioned, which was also very gratifying. So looking at these, the effective velar length is statistically different. It's longer. The effective velar ratio was in the normative values, but the maximum velar stretch is not as good. It's scarred. We won't run as fast after a knee surgery. So that was, I kind of understood that one as well. So of the measures, they pretty much were normal or compensated in this way that we're reconstructing with tissue addition. So just quickly, these are the cases that we see. This is a traditional case. They are not identical. It's just a story we're telling. You can get to this wonderful place, but it's about how easily we can do it and what we don't have to put these kids through. So this child is two-stage lip, bone graft, tissue, speech engine, and then a septoplasty. And this poor young lady, when she got to adolescence, needed to have 30 millimeter movement with a distractor by Dr. Polly. You can see that massive amount of movement. So she lost her speech and then had to have a few other surgeries. So by the time we get done, he's had 5 and she's had 11. So those are the things that we just kind of try to minimize. So how to do ACP operations. I'm going to talk about 2 real quick. The no-touch is a operation that's effective in the VO1s and 2s, good for Pierrot band, hypoplastic muscles, and it's actually good for older adults and where you can now use relaxing incisions because all the buccal flaps go into the velum. So in 1986, I added this because I was seeing cases that the muscles were so small I couldn't do a Z-plasty. I was just scared to have these little tiny Z-plasty flaps. They're not going anywhere. So I just released the entire unit as a single unit and put buccal flaps in. And so you've got these Pierrot band kids and you can get their buccal flaps reconstructed. Here's another one. When the uvula is the same size as the entire unit, you know you don't have a big unit. So this is where I will do relaxing incisions because it's not going to affect growth as much in the VO2s. So they stretch out even when you've got a really diminutive area. This child was 14 at the time that these were taken. Speech was excellent. A little bit of crowding, that'll be able to fix with orthodontics. So this is an example of that type of case. We'll show it real quickly here. So it's conceptually the easiest operation is you're going to cut this off, you're going to cut this out, you're going to sew them together, and you're going to fill in the blanks. So that's an easy operation. And for me, it's I think in big piece movements, little tiny piece movements, I think in the mouth are just harder for me. So I just release this. You get a good total muscle release because you're going to be looking at the hamulus right there. And I leave just a little bigger cuff on the nasal side, so it's kind of a 2-step cut. And I work side to side, get a little bleeding control, go over to the other side. So we'll just keep moving here. And now once I've released those, then I'm going to raise a buccal flap. So the buccal flap to me goes from, it looks like a 15 blade. It's kind of wider in the middle. And I mark out the parotid duct. And we raise those flaps. Now here's an important point. Right there's the eustachian tube. I'm going to be peeking at it in just a second. I'm going to look at it. Yeah, there it is. Okay, just behind that in this mass of tissue is the levator. It's going to come out totally wrapped in its normal anatomy. Now, you can argue that it's not freed up enough, and I can totally understand that. And I'm not going to, would never be critical of somebody if they wanted to free it up. Once again, the idea is to not have scarring around it, but I certainly, you know, you can get good results that way. But here I just, and now do a 3-layered closure. So it's closed, and now I have a defect. And Matma, you're looking at the adenoid there. This is for you. And now I'm going to hide it in just a second. Because now I'm just going to put a buccal flap on one side, like that. And it's there, and we can sew it in, and you're completely closed. And then we'll put the other buccal flap over the top. And now we're going to talk more about the lengthening procedure, so we'll go into more details about it, because this is essentially a lengthening procedure done in the primary repair. So this is a type 2 modified. So this is a Z-plasty and buccal flaps, but not a full Z-plasty. So this is basically a no-touch release on this side, but then there's a Z-plasty on the oral side. This Z-plasty, in order to get your buccal flap way in the front, is not just a soft palate Z-plasty. It goes in just behind this. You just kind of wave at it as you go by, and you can extend this way in here because this point has to be measured to get to that point. So these are beautiful pictures from Osama Hamdan's book that he asked me to do a chapter, and you'll see a few more of those. So this has been outlined how to do a Z-plasty, but sometimes you need extra tissue, and that's where I started, by adding extra tissue. So there's your eustachian tubes. So you're going to raise your buccal flaps, and then you're going to put the buccal flap on the nasal side. So here it is. Just looks like the no-touch we just saw. And now we're going to do a Z-plasty, but we're not going to go all the way across, because if you do, you're going to pull the soft palate forward, so you've got an area of deficiency here you have to fill in. And you can see the deficiency outlined in this David Lowe drawing. So you raise another buccal flap and put it in place like the diagram shows. Here it is getting in place. And it can go all the way to the front. Sometimes I'll do a hockey stick, whatever the outline. Per Hall is adding these fish wings on it, and he likes to maneuver them. So that's new innovation that is happening. And I'm sure that all of you, as you're using buccal flaps, are innovating in your own way, and I'm looking forward to seeing even more publications from all of you. So there it is, diagrammatically. The closure is, I just do a simple closure. It's one stitch down here, a centimeter above, and then just a running stitch, so that I have, to date, never had a problem with the parotid duct. And you don't get hematomas when they're that way. So a fairly wide VO2, this is what they look like. And there's your Z-plasty and your buccal flap. So you get good length, and the tissue in the front is really nicely healed. So you get these irregularly convoluted VO3s, and you can put your buccal flap in. That one I just got as far forward as I can. You don't push on a buccal flap. You don't stretch it out. You lay it in. You be nice to your buccal flap, it will be nice to you. And then you just deal with the rest later. So that's how that sits in. Here's what it looks like after the division of it. Here's what it looks like when you're having orthodontics in that same person. And I like to look at the way the teeth are in their proper position, not tilted in. There's not a lot of scarring. Orthodontists absolutely love working with these kind of arches. And these are the arches that you can get. And it's very reproducible. This is the redundancy that I talk about. It's built in. So if I got a fistula over here, I'm not worried that I can't close it. And I think that's a very important thing, because if you have a tight closure and it bursts apart, you've got your scarred tissue to work with to pull it together. Now you've got to use extra flaps like tongue flaps and these things that we don't really care about. But here, if you put the buccal flaps in the primary, they pay dividends, because they're there for fistula care and they're there for stretching as the child grows. So this is my practice in what I at the time called the anatomic palate restoration, and then later I started using similar concept in lip and nose work, which Mamda was so kind to ask me to talk about. So I don't usually talk about that too much. So this is a photo review. These are randomly chosen patients because I'm still getting my consents from the patients now that I've left the hospital. So these are the ones I could get consents for, and some of them are eyes are covered. Looking at surgeries for the cleft lip, primary palate repair, alveolar bone grafts, and rhinoplasty. These are the only surgeries that these patients have had. And this is the youngest that I'm going to show you, 14 and 16, because I just think this picture is so cute because she's scuffed up her nose and everything. And so this is when I delay it, I get these nice full lips that as they thin, they don't get a whistle deformity because it balances out. So he's 16 now. So she kind of snuck in. Normally I won't even look at a child until they're at least 16, but she snuck in. So he's a bilateral cleft with a Simon Arts band. He's one of my 3-stage lips where I've done nothing to his nose from there to there other than the 3 lengthenings that I do in those 3 stages. So, so that's where I left him. And then one of the fellows that's still in Grand Rapids did a little touch up on the nose. I'm not sure I would have done that, and that's his arch. This is a young lady. She had just the same series. She's had 3 kids. This is what the life we want these people to have. He's a complete bilateral. She's bilateral. There's bilateral complete, kind of a big Simon Arts band, more of an incomplete. You can see she's still got some little dental crowding. I'll take her nose. She needed more lip fullness, so I probably would have tried to make it even softer on her. Here's another one that's, she's now almost 30. She's here, you can see, I didn't get her nose exactly right, but her balance of her face and her speech I got well, because I tried to match, she's a twin. Facial projection is good. When she smiles, her better balance. We're not hearing it. Oh, you didn't plug it in. Sorry. Give me 1 second, see if I can do this. Oh. No, it's on. No, I didn't change the setting. I didn't change anything, I just pulled that out. Well, I'm gonna. So anyway, he's playing the tuba. He's a bilateral cleft, and we didn't plug this one. This is the one we needed to plug in. Anyway, the fun part for me, and when I changed over to this, and I'm so excited when I come and hear from you the stories that you're starting to share about with your successes, because it makes the practice so much more fun when you watch the kids grow up and you can really focus on the ones that aren't doing quite as well, because you have fewer of them. At least I did, and I'm seeing a lot of people that are having the successes in that. So it was in that one. We went to headphones. No? It's okay. This is a long day. So William, anyway, the fellow who was playing, he was adopted at age 6. So fixed his palate at age 9. He was singing in the choir in the high school musicals. And he's in college here. He's playing Phantom of the Opera on the piano with one hand and the tuba with the other hand. So it's so I don't have a rock star, but I got a music star. Keep going, keep going, keep going. Keep getting there. There you go. That's good, that's good. It'll continue to play. This gentleman just had a second child. So this young lady was a speech pathologist that was in a program, and I was doing surgery, and after surgery, I said, "Would you like to sit down? I'll tell you about the operation." She said, "No, I think I know a little bit about it. You did my surgery 26 years ago, and by the way, I sing opera." And I said, "Oh, I gotta have your opera." So this is her singing, and she's a speech pathologist in Detroit. So like I said, they look like your neighbors. This is a fellow I lost for follow-up for a long, long time. There's a farmer in Michigan, and he just came in. I ended up doing his nose, but I liked his facial balance. He had no speech problems, so. She's bilateral. She was one of the early ones where I did the work on the nose. Would like to do her nose over again. And that's part of it. Oops, sorry. She's bilateral cleft lip and palate. So it's not statistics, but to me, it's what I look at when I think of the direction I want to go. Look at your pictures, be real critical of what you do, and that'll show you the direction of what you want to do. So if anybody is interested, this is kind of a leap of faith. It's going to be worth it. ACRP, for me, it really was a game changer. It's how I managed it. And really a life changer, for your patients and for you, can be. Thank you very much.
Thanks very much, Bob. And thank you again for sharing with us your long-term results and waiting so long to publish them, to really share with us what we talked about, that it takes a lifetime to really share the lessons we've learnt in cleft surgery. We'll go to our final talk for the session. Percy Rozelle, Cleft Palate My Way, Palatal Fistulas, How to Avoid When Repair. Percy needs no further introduction. He's written many textbooks about cleft lip and palate surgery, and we look forward to hearing about his approach to cleft palates.
Thank you. Thank you, David. Thank you again for the opportunity. I'm going to present that personal experience in cleft palate repair, and with focus here on, right? I think that that one. Focus on prevention of complications. That is I want to present now. Excellent. And this is the one. Okay. Thank you. It's here. Okay. Excellent. Thank you. Right. Objectives: how to prevent main long-term postoperative complications, and my personal strategy to address the cleft palate deformity. Main long-term postoperative complications, they are the palatal fistula, velopharyngeal insufficiency, medial ear dysfunction and hearing problems, and also mid-phase hypoplasia. Fistula prevention. What about this? That we understand, in my personal experience, is the best way to prevent the fistula development is the one-stage protocol, the blood supply preservation, and the palate closure without tension. These three basic principles are very useful tools to prevent fistula prevention. So, to prevent fistula, a palate closure without tension, using relaxing incision as necessary, and the greater palatal pedicle radical dissection. One-stage protocol. This is a meta-analysis. Conclusion: one-stage repair associated with less risk of fistula formation and BPI than two-stage. This is logical because why? Because when you are coming back to perform the second stage, the tissues, they don't have the same quality as the primary time. The flexibility is not the same. That is why almost, or maybe many papers publishing, including meta-analysis, are concluding that the two stages, they have more fistulas. That is, it is logical to be understood. Studies here from A.B. Holm, Oslo Protocol, very common actually, also Summerlad, 14 to 18% of fistulas. If we want to present midface hypoplasia and we have fistula, 3 surgeries is not affecting more the fascial growth than 2 or 1 surgeries? Of course. So this is a contradiction. This is the soft palate, delayed soft palate closure without relaxing incision, which is a modification proposed by Dr. Summerlad, is 16% of fistulas. Delayed hard palate closure from Friede and Lilja from Sweden, this is the Oslo protocol, closing first the soft palate, is 8% of fistula. In good hands. In good hands. Two-stage protocol, oronasal fistula, this is a meta-analysis, 2021. The Bowman-Flap technique in cleft palate repair appears to be associated with low. This is the conclusion. However, when you see through the study, you can see clearly that they are using the Oslo protocol. And the Oslo protocol is using the von Langenbeck and relaxing incisions. So I think it is a contradiction of the conclusion because the two stages is allowing us to get low rate of fistula. The low rate of fistula probably is associated to the use of the relaxing incision in this study. Blood supply preservation. This is very important because our protocol is based in this concept. This is the worst complication in cleft palate surgery. It's not the midface hypoplasia. Not almost, probably many protocols. There are more than 200 in the world. They are trying to avoid the midface hypoplasia. Well, we can correct the midface hypoplasia. We can do alternative surgery. But what about this case? This is really, maybe we never can appropriate this problem. So, in that way, I consider in our protocol, we have to preserve the blood supply of the palate as the main objective to prevent severe complications like this. This is not uncommon. Let me tell you, probably you are a good surgeon, you have experience. I have never seen, probably, you are a very lucky surgeon. I had one case, and after that case, I have changed everything in my protocol because this is the most terrible, well, the complication after cleft palate repair. There is no palate here. Look at this. This is a study we did, and we identified that the cleft type and the severity of the palate, they are predictor factors of palate necrosis. So we have to pay attention in bilaterals and incompletes, and also severe forms of cleft palate. We have to pay attention. Not all the cleft palates are the same. There is not a unique receipt. Again, it's the same when it's cleft lip repair. There is not a unique receipt to address the cleft lip and palate. Okay, we have to consider the patient, severity, the type, the technique, and the surgeon. Blood supply. This is very important to be commented. This is an incomplete, right? But in the incomplete, there is something similar to the bilateral because the vascularity is not like a normal palate. Of course, there is not a cleft here, but the anatomy used to be like this, that the vascular blood supply is coming from the back, but this is not performing an anastomosis with the anterior system. And if you're performing a monopedicle flap, like the Bardach one, the two flaps, that you are supporting the vascularity in the posterior arteries. So, in that way, we're stopping doing that the two-flap method because we want to receive more blood supply to the flaps coming from the anterior portion and the posterior portion, and I explained in our protocol. This is the unilateral deformity. It's different. Probably in the hypoplasic side, this is the cleft side, the anatomy is similar, okay? But here is probably normal because we have an anastomosis between the posterior and anterior. And this is the tissue, the good tissue to repair the cleft. And the incisions should be limited in this side, as I'm going to explain in the protocol. This is the bilateral. Look, the blood supply is coming from the posterior portion, and there is no anastomosis with the anterior one. In that way, we have to preserve the anatomy of the blood supply and trying to increase the blood supply coming from the anterior portion, limiting the relaxing incisions. Fistula prevention, palate closure without tension, and the use of relaxing incisions as necessary. This is a publication from the United States, Dr. Timmons, 0% of fistulas using relaxing incision. Palate closure without tension. Look, this is a randomized clinical trial. We did a study to understand how is the relaxing incision working. Because the surgeons who like the two-stage protocol, they said the relaxing incision is producing the mid-phase hypoplasia. But there is no single study demonstrating that. There's not. I will try to understand. If the relaxing incision is laterally, so the mid-phase should be affected in that way, transverse. But we know clearly that the affection of the mid-phase growth is in the anterior portion. So there is no sense. And I believe that the relaxing incision is not affecting the mid-phase development. This is a multifactorial problem. Okay? We did a clinical trial. We compare one palate using bilateral incisions and the other one using a technique we published it that the one flap. This is unilateral. Only one side with incisions, the other both sides. We expect a problem in this side, right? In comparison with this, because there is an incision here. But this is not happening. This is the outcome. The outcomes, the slide before and this. And we haven't seen any difference between the two groups. Look, one group, two flaps. This is the maxillary arch. This is the occlusion. And this is another one. Look at the maxillary arch, no orthodontics, one flap technique. And this is the follow-up until the mixed condition period. This is a clinical trial. You can read it in internet because it's accessible. And fistula prevention, palate closure without tension. This is a key point. I like to say that the palate surgery is the surgery of the greater palatal artery. It's the key point. The surgery of the cleft palate is the surgery of the greater palate, like this. This is during the surgery, this is the flap, this is the relaxing incision, okay? Soft palate here, hard palate here. Look at the dissection of the artery. That is the key point. Yeah. Completely mobilized. This is a blunt dissection. I know surgeons, they like the sharp dissection, but I think it's in higher risk. But this is blunt dissection. Can be done, and you can mobilize very well the flap. This is another key point I like to share. I like to close all the palates using FIO. FIO, that's the suture. Because if I can close the palate, it depending of the width of the cleft. It can be wide, can be narrow, independent. If you can close using the FIO, it means there is no tension. And this is not in relation with the increase of fistula rate. This is an important tip. BPI prevention, early surgery, palatal lengthening, muscular repair, doing intervaloplasty or furlough, and also fistula prevention if it is a very great size of the fistula. These are the tips for prevention of the BPI. Mid-phase hypoplasia prevention. This is a randomized clinical trial. 2021, the surgeon this is the conclusion. The surgeon was the major factor that influenced the dental-art relationship. Probably this is true. You know, this is multifactorial. The answer is not, there is no holy grail. The technique is getting all the answer. This is multifactorial. This is the patient, it's the surgeon, and the technique. Midface dysfunction, ear dysfunction, and here, early surgery, muscular repair, and anatomy preservation. This is the key point, I think. I'm going to explain in the next slides about this point. Personal strategy, first, cleft palate classification. These are bilateral, and also this is bilateral. Do you think that this is the same as this? No, but we consider this is Beaufort. You know, oh, this is Beaufort, and also this is Beaufort, but they are not the same. So, can we do the same thing here and the other? Or we need an individual strategy? That is, we believe that we have to do an individualized treatment for each type, depending on two criteria. The type, bilateral cleft, and also the severity. In that way, we create, this is common classification, Bo, Kernighan, but this is only anatomical. But there is not any description of severity here. As I showed you before, we created a tool to evaluate severity, and this is the index published in Journal of American Medical Association, and this is the index between the width of the cleft and also the width of the palatal segments, and you have an index. This information, in combination with the type of the cleft, is useful to do an individual treatment. This is incomplete. Excuse me. Here. 3 degrees. Mild cleft palate, moderate, and severe. The index is less than 0.2, moderate between 0.2 and 0.4, and more than 0.4 is severe. Okay? 3 degrees of severity. This is the Lima protocol. I am Peruvian, I live in Lima, I'm born in Lima, this is the capital of my country, and I said, there is Oslo protocol, Gothenburg protocol, why don't Lima protocol, right? So we decided to publish and use this personal strategy to address the deformity. And what is this about? This is the concept. Early surgery, right? 9 to 12 months. Individualized treatment based on type and severity of the cleft, combining strengths from 1 and 2 stages. And this is an interesting thing. This is the first protocol in the world who use the strengths from 1 stage and 2 stages. Because most of them there, or 1 stage or 2 stages. But this protocol is including the strength from both. I would like to explain now. 2 layers closer without tension, reduction of the relaxing incision to improve vascularization, not to prevent maxillary hyperplasia, as I explained it. Non-radical intravelar veloplasty, and this is a very interesting point I would like to explain why non-radical should be done. Innovative veloplasty I'm presenting, unilateral uvuloplasty. This is another innovation. Let me tell you, this is a Peruvian innovation, and published and can be demonstrated. What is it about? Hard palate, soft palate, and uvula. In hard palate, we're using bipedical flaps or the technique of the 1 flap for the unilaterals. The soft palate, we're using furrow for both 1 and 2, and also the innovative veloplasty I'm going to show you. And for the uvula, we're using the unilateral uvuloplasty. Hard palate, let me show you. Incomplete deformity, 3 types: mild, moderate, and severe. For type mild, incomplete, we are using the furrow technique, 1 stage. For the moderate, we are using the hybrid type, including the furrow plus lateral relaxing incision. And when this is severe, we're using the von Langebeck. 1. Unilateral, look at this. Mild, moderate, and severe. For mild, we're using a hybrid technique, lateral incision only. Here is the 1 flap. This is published. Instead of the 2 flaps, we're using the 1 flap technique for the unilateral cleft palate, using the non-cleft side because it's bigger and well vascularized. Look at this, the one flap, and the hybrid technique using the one flap plus a minor relaxing incision here for severe. This is the one flap palatoplasty, published in PRS. You can read it there. This is a study. We studied the two flap against one flap. There's no more fistulas. You can read it. It's accessible. Bilateral. This is the big problem, the bilateral. Mild, moderate. Mild, using only one lateral relaxing incision, preserving blood supply here and here. This is for moderate and using the bone line back, which is receiving blood supply from the anterior portion, because this is the bilaterals are in higher risk, as I show you in the study, for development of flap necrosis. What about severe? This is the real problem. When the index is more than 0.4, you have two conditions. If you have a severe bilateral cleft palate and the patient comes to you before 6 months, then you can do the Gothenburg protocol. Why? Because the Gothenburg protocol have a good strength that it's close in the hard palate. If you close the soft palate, then you have not a severe, you have a moderate or mild bilateral cleft palate. Then you can do a hybrid or bone line back, preserving blood supply. Like this. The problem is when the patient is coming after 6 months, because it's very difficult to correct the size of the cleft width when the baby is operated after 6 months. And then if you close the soft palate, then you have a problem because you are closing the hard palate, you have a scar tissue here, and the width is the same. So in these cases, I am using one relaxing incision on one side and one flapping other side to close, like this, the palate. Of course, this is not the ideal condition because I am using here a monopedical flap. Ideally, the baby can be operated before the 6 months if it is severe. Soft palate, furlough, or radical intravenously veloplasty are common methods to operate the soft palate. These are the unanswered questions. The people who is performing radical intravenously veloplasty don't know these answers. Why are you expecting normal function if you're cutting a tendon who is providing function? Why do you need to cut the tendon tensor to repair the muscle, expecting speech, normal speech, but I'm expecting normal here because this tendon is producing a function. So all these questions, the role of the tensor, whether to preserve the fascia along the elevator, how to measure the descending and transverse fibers of palatopharyngeals, how radical is safe to mobilize, all these questions are unanswered. So my question now is this. If I don't have these answers, can we be radical without these answers? If you perform a radical intravenously veloplasty, then you can go back. You cannot do a conservative treatment. If you do a non-radical intravenously veloplasty, then you can do a radical form if you want, of the patient needs. This is very important to be considered. What about the studies? Let me show you. This is a very popular study. This is Jeffrey Marsh. He is from the United States. This is a 1989 study. But the interesting thing, this is a clinical trial. This is a high level of evidence. What do they conclude? The findings suggest either that there is not beneficial effect of intravelar veloplasty upon palatoplastic velopharyngeal competence. They compare two groups. One group, no intravelar veloplasty, and the other, Crines. The Crines intravelar veloplasty is a kind of no radical. They compare. No difference. That is crazy because actually we are looking for the radical. What about this? And there is one more information that is very interesting. Look at this. This is a study performed by the same team 28 years after the first study. What do they find? Look, they did a survey sent to the randomized clinical trial participants 28 years ago. This is a long-term follow-up for the ones who likes the long-term follow-up. variables: speech intelligibility, secondary velopharyngeal needed, facial growth, breathing during sleep, attainment of education, and long-term socioeconomic status. Many variables evaluated through a survey in these patients who participate in the randomized clinical trial. 40 patients from the 200 patients in the original study answered. This is a limitation. Conclusion: the two groups have similar outcomes in terms of need of secondary velopharyngeal management, education, career choice, speech facilitation, dental occlusion, sleep disorder. The half of these patients didn't receive any intravenously veloplasty treatment. It is interesting to be considered. Now, can we perform a radical treatment? Is that necessary? How many studies comparing, clinical trials comparing radical form against non-radical exist? There is none. So there is no answer to this question. Look at this. We did a systematic review. Most of them are retrospective. Retrospective, only these. Look at this. Here, this is a randomized clinical trial. The other are retrospective. They cannot answer a therapeutic question. And this is better speech outcomes were observed using Furrow technique, and middle ear function was not measured. That's a limitation. What else? Here, look. Here, prospective randomized double-blind study. Both techniques yield similar audiologic and otologic outcomes. Need for tympanostomy to placement did not differ by the type of palatoplasty. Speech outcomes were not measured in this study. Other are retrospective, not a good level. This is the non-radical. What is this about? Preserving the attachment of the tendon tensor. That is the difference only. Here, this is a study. We observed the need of ear tubes was increased in the radical form because we were doing radical form. I'm not talking about that we didn't use. We use that. It's the same as NAM. We use NAM during years, and we observed that this is not necessary for unilateral. Here, that is a study for the innovative palatoplasty. The innovative palatoplasty for the soft palate is this. You are elevating the muscle in one side. You are creating a nasal mucosa flap here to here. This is the intraoperative view. Then you are moving in a transposition flap to the other side. And then the muscle and the mucosa is moving to the other side in a transposition form, exactly that Furlow recommend for nasal laning. And finally, you have an overlapping of the muscles. Here, this is what you have before, and this is what you have after surgery. Let me show you an animation, please, here. Sorry, just a second. I'm trying to respect the time. Sorry, will you please help me? I'd like to show, please. Yeah, just to, because remember it was working well, but that is working. Okay, that is an animation. Look, that's a unilateral vulvoplasty. I will show you a video now. Look, we are closing the nasal mucosa. This is the one flap method for unilateral, right? We are elevating here in this side the muscles. This is the nasal mucosa. We have a flap for transposition. Then we are moving the muscular mucosal flap to this side, closing the nasal mucosa, and then they're overlapping. That is basically, and we are not performing any incision in the oral mucosa, preserving the blood supply. That is the point. The uvula is performed. I have never, let me tell you, repairing the conventional method using one half and the other, to me, it was really difficult, probably because of my surgeon limitations. And I decided to move to the unilateral uvuloplasty, which is this, removing one side and using the preserved uvula, and the outcomes can be achieved. We did a clinical trial here, and also we demonstrated functional effects of this type of repair in the soft palate because there is a small lengthening and reducing of the velopharyngeal space. This is a study. You may review the study because it's accessible. We did imagine a study to complement and to evaluate the functional effect of this unilateral. Look at the outcome. This is uvula. Now we have an uvula, and also here. And to end, I like to present, this is the, let me show you, just to finalizing. Look, this is the unilateral rubuloplasty.
Then, we have performed a small incision at the
This is a small cut, just in the oral side, to preserve the blood supply, just in the oral side, there, preserving the uvularis muscle also. These are midline incisions on both sides,
are performed
there,
laterally.
and also in that side the same,
Busy here.
right? And we are using this tissue to close. I'd like to run a little here. Yeah, I think.
Uvula closer. is
I
performed.
like to, please, I need to run a little because of the time. I don't want to extend my presentation, but I would like to run a little. Please, Doctor, how can I run it? Because this is stopping. Right. This is stopping, yeah, because it should appear here. Now, okay. Okay, but excuse me about the time, but no, there's no. Okay, but I can do that. I'll show maybe during the break because after this I am showing that the palatoplasty that technique, or maybe we can wait. But this is taking I think probably 5 more minutes. That's too much. Okay, so I would like to run. Okay. Yeah. Oh, yeah. I like. Oh, yeah, yeah. I think, yeah, okay, that's excellent. Thank you. Thank you very much. Thank you, sir. I'm very happy. Okay. And then, okay, I'm running here. Just closing. That is a C plastic here. Look, this is a kind of C plastic, and this is a small lengthening, of course. But when we are moving the uvula to one side, we are reducing the velopharyngeal space also. This is a small change, but as Dr. Robert Mann always say, small changes in the velopharyngeal space is producing functional effect. Okay? And I would like to finish this video showing you that is final outcome. Look at this. This is the veloplasty. I am elevating the muscles from the nasal mucosa here. Look. This is I think it's not really a problem to elevate the muscles from the nasal mucosa. You can do that. I'm using a knife to do that. It's not with scissors, so you can do that. Look. And I am preserving the attachment of the velar muscles to the hamulus. Look. That is basically that I'm doing as a conservative way to elevate. Then I am moving, look, that is the nasal mucosa flap. That one is the nasal mucosa flap. And then I am cutting here, that is the muscular mucosa flap. From there to there. That's it. And I am closing now. Look, this is the nasal mucosa here. And this is the muscular mucosa flap in the base, closing there, and finally, let me show you, we are closing there, and finally, look at the muscles, this is an overlapping, right? This is an overlapping from this side to the other. It's in fact, this is a modification of the furrow, okay? Lima protocol, studied, published, you can see the differences between the conventional protocol using 2 flaps against the protocol using different techniques for different type of cleft. This is very important. I will present to you my experience. But I think in some way we are artists, right? Because we are using our hands. So we need science to prove that we are doing, and to demonstrate that this is better or worse than other option. Okay? If you study your method, probably there is a conflict of interest. But when somebody is studying your method, like it is happening in the case in Indonesia, then you can see clearly if the things are going well or not. They are my books for sharing for you, and thank you for your time, your patience.
I'll get the speakers to come and join me up on stage, and we'll field some questions. So Bob and Percy and Congrats. I just start off with the. Oh, sorry.
Just one announcement, because we are short of time, so we're not going to have a coffee break. We just have this 5 minutes for questions, and we're going to start the next session, okay?
Great. I think the discussion's very important. It's a real opportunity for you to ask your questions. The cleft palate is such a complex issue. I might start the questions, though, with Bob. Bob, you're showing some great growth results. Can you speak a little bit more about what you think is giving you the good growth results? Because you're still obviously doing a lot of dissection to get especially the hard palate closed. And you also, it sounds like you might be getting fistulas at the front, which you're intentionally okay with because of the buccal flap approach. So where do you think you're, because it's the growth that I'm particularly interested in.
So the growth is looked at skeletal maturity. So when the kids get to be 16, we have them evaluated by oral surgery, orthodontics. We have at least three orthodontists and at least one, usually two people that are going to do the orthognathic surgery. So I don't make that designation at all. And that's the part when it's determined, are they going to, do they want to go with what we try to have them set up so they don't have a compensated arch, so they have a place for the laterals and that sort of thing. And if the child has syndrome or something, then maybe they'll say, well, we want to lateralize a canine and we can go this way instead of that way. And so that's when those decisions are made. The closure of any of the anterior openings that we leave, like in a bilateral, like we talked about, will then close those all at the time of bone graft, so that it's all closed. Yes, I guess that's a staging, and I think for me, and that made sense from all the things that I was seeing. So that's how I did that. And as far as the dissection, I think when you do stage it, you're not damaging any of those blood supplies that Perry was talking about. So I think that it probably helps there. Growth. As I say, the thing that was most amazing to me, just personally looking at all the kids, was the kids that were closest to normal in their face, the way you look at them, the way they function, and when form and function come together, I think that gives you the biggest opportunity for whatever growth you're going to have. I mean, 7% of the normal population of Caucasians will have dental facial imbalances. And so we can't expect that our cleft kids are going to get to that even. But I think if you can minimize the scarring of any kind is a good thing. Quantifying scarring is very, very difficult. And so I think that's the hardest thing that you have. I can't stand here and say that this is more than that. But if you kind of look at it, most people, and once again, from a scientific standpoint to say this, you could jump on it and say, when we did early bone grafting, those kids very quickly had crossbites. And if you look at a child who has a crossbite at age 6, a lot of times they're going to end up with, growth issues. So most people won't do bone grafts early anymore. relaxing incisions, it's not the relaxing incision that causes the problem. It's the tension, it's the transposition of the periosteum, it's that tightness that is associated with the need for the relaxing incision. I don't know. I mean, I'll ask Perry later what it's been a while since I read your article, but how old were the kids where you're looking? I think they were still just before skeletal maturity, and I think they were also done in your classification system, in your randomization, when you put the relaxing incisions, they were kids that you could close without relaxing incisions. Am I right on that?
Yeah. Sorry.
So,
We did a conventional randomized clinical trial, randomizing the groups first, and then using the technique from one and the other. And one group received the two flaps, and the second group received the one flap method.
oh, so they both had relaxing incisions. Just
Yeah.
one had one and one had two.
Yeah, sure.
Okay,
That
so you're
was-
comparing those two groups. Okay, I read your article, but I knew that they weren't like 18-year-olds, they were a little bit younger.
Yeah, of course, you are right. That actually, you know the ScanClef, right? The ScanClef study?
Yeah.
Yeah, this is a multi-center randomized clinical trial, and they are in process. They don't have final outcomes because they are in process, and they are looking first for the mixed deletion period time. That I did. We did that the first time is the mixed deletion, and then we are waiting for the final
Got
outcome. Sure, that's
Got it.
clear.
So,
Sure.
I don't want to say preliminary because it's appropriate to do that in mixed dentition. It's just a mixed dentition study. But anyways, did I answer that question? I don't really have, I mean, I look at the kids where I have CEFs that are, hopefully we'll be able to evaluate. But CEFs on their own are not the best way to evaluate facial growth either. It's you have to have a dental models, you have to have all these things. So we're still exploring the best way to look at the kids. As I say, as a single guy in a small town, when you've got the kids who look normal, I've got large numbers, this is where I'm at. And then I'm, looking at the people who are using buccal flaps and their successes going forward, that's a confirmation of the direction as well. So I guess that's all I have to say on that.
I'm particularly interested. I mean, Mahmoud and Mahmoud, it was a beautiful talk. I thought you summarized the evolution of the way of thinking of cleft palate very well. And I'm particularly interested, Mamdouh, that, we grew up in the similar philosophies with the two-flap platoplasty, watched the evolution from pushback to two-flap to Summerlad now to furlough and buckle procedures. You're passionate about buccal flaps now, and you've been using it for, sounds like, about 5 years. I can see speech-wise why, lengthening the palate would improve speech. Have you seen any growth improvements yet? And why have you become so passionate over a reasonably short period of time in your unit?
Yeah, as we had our chat on the coffee break today, the gross matter is really getting into my head a lot. And what I really noticed and I've seen is the arch shape after 5 years. Now we're getting the speech outcomes. Iman is helping me with that, and we really had very good results. And the arch shape itself, if you find it in most of the two-flap palatoplasties, whatever the type done, is usually angulated like that. Most of our cases, we still have some of that with the vaccinator, but most of our cases actually the arch is rounded and it's wide. So I'm really very optimistic about the results. Next year we're gonna get about 50 cases. We're gonna scan them and take this transverse and longitudinal measurements, and I'm comparing them even with my older cases of the two flap that I've done. But what I noticed well is the dental arch itself, the shape itself is really looking better. So I think it's a start. I'm looking, as Mahmoud said, and Dr. Mann and you yourself and Percy, that it's still, you have 15 years. You have to live 15 years, at least, not 15, it's 25 years actually, because you improve yourself during your first 10 years to get to what's totally getting into your mind and your hands, and then you start evaluating these results. I've been taught the furlough with Dr. Mann and Dr. Ketchner and Lucy, and I think I have my own different technique than them. And each one of us have his own. I'd say it's the name of the operations, but it's unique to the surgeon. I do small triangles. I do different steps. So to see this on a large number of cases and follow them with the same surgeon, I'm encouraging that to compare our results, each and every one of you, and the data is easily to be collected now rather than the old time.
Yeah, so just to be clear, what Mamda, I think your approach right now would be in my hybrid group. So he's not doing exactly my end group. He's doing an online foamer flap in the front, which has some impact. We'll see. If it doesn't, that would be amazing, and I'm hopeful if that's the case. But that's the innovation that everybody, I think, is going to have. Just like you've innovated the fissure repair, right? I mean, you don't do it exactly the same way because you have feelings about the nose and where you came from. And so you're going to be longitudinally looking at your growth and results and how the nose is. And I think this is a new technique that is now just taking off, and that innovation is going to start. And that's exciting for me, and I think that's why he's so excited, because it is exciting. I think that Perry has taken the intervelloplasty, and the people who are doing radical are moving this direction. I think you're in that group, and you're very comfortable with it, and you're seeing repeatable results at a specific percentage we've talked about. And Perry, I think it'd be pretty clear you're going this direction, and you're innovating it in different ways, but still within the concept of the intervelloplasty as opposed to tissue addition. So there are three different kinds of approaches that are still kind of going, and because of the longitudinal aspect of looking at growth, it's going to be a long time. But I think initially I look at speech engines separately, and I think that's pretty clear that is showing good results right now.
Right. Please.
I just want to make use of this wonderful chance to have all these experts on board. And being an ENT surgeon, Dr. Russell mentioned that you preserve the tendon, right? So this is the standard now, is not to cut the tendon, or not to, we use even to break the hamulus, and then we are cutting the tendon now. Me personally, maybe Tariq is not, we had a conversation about that. Cutting the tensor tendon, what exactly does it have an impact on hearing or not? I personally believe that it does not, but I would like to listen from you. Do you preserve the tendon just because it helps the middle ear function to be better? And is this true? Did you prove that this is better for the ear?
Right. Okay, there are many questions there, but we didn't demonstrate, in fact, that the conservative, the non-radical is better than radical. We didn't. We did study, but this is observational. And we know clearly that through observational study, we cannot answer therapeutic questions. That is the truth, right? It's just observational, right? Because it's difficult to perform randomized clinical trial, right? But it is logical without the answers, because this is an unanswered question. What is the impact of the section of a functional structure? So we may expect something will happen. We don't have that answer, because we need, methodologically, we need a method to prove that hypothesis. You know? Oh no, this is kind of common sense. You know, that if you are preserving a functional structure, you may not affect the function. That is only the concept. In fact, in the practice that I'm doing is preserving the structure, and I'm looking the outcome. Let me tell you, as Dr. Mann mentioned, we are changing during the time. Maybe this is confusing, especially for the beginners, because they are looking many techniques, many protocols. There is too much, right? But during the time, we are changing because of the need. We are looking for the need. In example, I've been doing Millar during almost 10 years, and the outcomes not good. Probably some of them. And I said, I have to change, right? In that way, there are some specific points during our experience that we believe that we have to change based on needs. Why do I have to change if the outcomes of the patient during the time, followed during the time, are I am expecting as an outcome, as a good outcome. I am measuring that I can do. I don't have all the answers, but that I am measuring during the time, including some trials, is indicating to me I'm going in a good way. So in that way, I don't need any radical change to move to use flap for primary repair. Because I believe that I am looking at my patients is that this is functional, right? But I am answering you in a kind of personal experience, right? But this should be answered methodologically, right? If it is not happen, then everyone have a truth. You can say, in my hands, everything is going well. I can say the same. Everybody can say, well, I'm doing well. But we have to prove that we are doing is better or worse than the other option. That is very important. That is why the technique should not be evaluated in a case series methodology. That is a descriptive study only. Could be good in the hands of that surgeon, but not in other hands. That is why the case series is not answering an hypothesis or research question about the technique. That is why we need science. If not, everyone has a truth. That's my...
I'm sorry, we have to wind everything. One last comment.
I think it's a very good point that you make. I mean, it's the blend between ENT and plastics and looking at middle ear function. I think we've got to look to why the tensor used to be transected. The people used to transect the tensor or fracture the hook of the hamulus because they were worried about tension of the closure of the repair. So they were willing to sacrifice the structure. The question is that, will there be a functional problem from the sectioning of the tensor? And this is the only two things that I know of. Cork Cutting used to talk about putting a stitch into the tensor around the hook. He called it a tendinopexy, and he claimed that he got better middle ear function from that. And Summerlad also claims a similar thing, that when he repairs the levator aggressively, that he gets better middle ear function. I think what Percy is saying is that obviously from a scientific point of view, it's hard to know, but from a surgical point of view, I don't think you need to ever section the tensor to close the occasionally in very, very wide palates, like when I'm trying my best not to get a fistula, especially in a VO2, I'll go out to the medial pterygoid plate and I'll mobilize all that mucosa to help me close it. And occasionally, when it's a very wide cleft, I will release the tensor origin from the medial pterygoid plate rather than section the tensor. And that's purely from a mechanical point of view, that I want to close the two-layer tension-free. Exactly.
Okay, thank you everybody for this nice conversation, and we'll move quickly to the following session about the VPR assessment and treatment. And thank you everybody for this. Thank you, Bob. Yeah, we'll continue, yeah. And we'll have the break later. Sure.
So this session, we're going to be talking about treatment of speech, and we're going to be starting off with a comprehensive speech assessment in patients with cleft lip and palate. Dr. El Rudy, who is going to tell us about that. So the stage is yours.
Okay, thank you. Good afternoon. I have the pleasure to be with all the surgeon experts today, and I'm really enjoying it here in Luxor. I'm going to present today something from a different perspective. So we're not going to talk about surgeries anymore. We're going to talk about speech as an outcome of these surgeries. I'm Dr. Iman Ruby. I'm an assistant professor of phoniatrics in the Hearing and Speech Institute, and I'm also a speech and language consultant in SmileTrain. I'm lucky to be a member of this great team. We have a comprehensive Clift care in Kids Hospital. Our leader is Dr. Mamdouh Abul Hassan. We have Dr. Tariq Abdel Fattah, ENT consultant, Dr. Mary Shaker, our nutritionist, Dr. Mohammed Abdel Ghafour, and I'm the phoniatrician. Okay, so what is velopharyngeal insufficiency? Velopharyngeal insufficiency occurs in patients with cleft lip and palate due to the structural defect. And it's presented in hypernasal resonance distortion, and there's nasal emission during speech. So if we look at this diagram, we can see here that the velum normally is resting on the base of the tongue during rest. However, during speech, the velum moves upward and backward, touching the posterior pharyngeal wall and dividing it to two chambers, the oral chamber and the nasal chamber, which is essential for differentiating between oral and nasal sounds and for the resonance. Of course, we know that we have different muscles elevating the velum and depressing the velum. Of course, all of us know these muscles. And this is the role of this velopharyngeal port in differentiating between the nasal sounds and the oral sounds. Speech sounds are formed of vowels and consonants. All the consonants are oral except for 3 sounds, n, ng. These are nasal sounds. And for the oral sounds, we need this door to be closed. The port, we need the door to be closed in order to avoid air passing through to the nasal cavity and causing hypernasality. Also for the vowels, but for the nasal sounds, this velopharyngeal valve is open. As we said, the nasal sounds are the m, ng, and ing. Sounds are also differentiated into high pressure sounds and low pressure sounds. For high pressure sounds, example, the p and ba, ta, da, ka, ga, sha, cha, and the other sounds. These sounds need a strong intraoral pressure, and this is obtained when the velum is closed, okay? But for low pressure sounds, the port has to be closed also, but not to that extent. So if we face any patient with cleft lip and palate with speech errors, mainly the sounds that are affected are the sounds, the high pressure sounds, because these need a good closure, a good velopharyngeal closure. So when do we assess these patients? Assessment is done pre-surgically and post-surgically, whether the surgery is for primary care, primary cleft repair, or secondary cleft repair, and whether we do this assessment pre-surgical or post-surgical after the repair. However, we have a timeline for each age group. We concentrate on certain assessment points. In the period from 6 months to 3 years, this is the period where we concentrate on language assessment, language development, because most of the children, because they perform several surgeries, So they usually have language delay. So on this period, we concentrate on the language assessment and language stimulation. From the period from 3 to 5 years, we can do now speech assessment, perceptual speech assessment. And if we need further instrumental tools, we may use a nasopharyngoscopy to confirm our diagnosis. And this is the period where we can start speech therapy. And I was having a discussion with Dr. Robert yesterday. The children that are really cooperative in improving their speech errors mainly are starting from 4.5 to 5 years and till 6 to 7 years. This period from 3 to 7 years, this is the period, maximum period of brain plasticity. And when they are older than 4, these children are more cooperative and they understand what you need them to do. Okay? The period from 6 to 12 years, this is the period for orthodontic care and alveolar bone grafting. Also in this age group, speech therapy is essential. However, later on, from 15 to 20, these patients continue with the orthodontic care and orthognathic surgery, but speech reassessment needs to be done because some operations as maxillary advancement may have like an adverse effect. If speech is improved, this maxillary advancement may worsen the speech. But Dr. Mohammed Hussein says that he didn't face that. Okay, how to do the assessment? Assessment of speech is done through several steps. The first important step is the auditory perceptual assessment. Okay, we have simple tests, clinical tests like the AI test and the cold mirror test. These detect the hypernasality. Intraoral examination, further investigations like nasopharyngoscopy, videofluoroscopy, and nasometry. So I will discuss till nasopharyngoscopy because these are the assessments that we usually do in our cleft care center. We don't have videofluoroscopy and nasometry, so we usually don't prefer them. But if we need them, we refer patients to other places. So to measure the speech outcomes, there are universal parameters, okay? And these parameters have scores. We give scores for hypernasality, hyponasality, any speech errors, nasal emission of air, any compensatory production errors. There's scoring for speech understandability and speech acceptability. And according to these scores, hypernasality scores, it determines whether these patients need speech therapy or whether they need further physical management or surgical intervention. Regarding the perceptual assessment, as we said, we comment on resonance. And we have to detect if this patient has hypernasality, hyponasality, or mixed resonance, or cul-de-sac. And we have to differentiate between hypernasality and hyponasality because we have many patients that are referred to us. Maybe they're not cleft lip and palate patients, but they have a hypernasality or hyponasality issue, and the referring doctors could not differentiate properly between them. So what's the difference? Hypernasality, this is too much sound resonating in the nasal cavity. And the causes are usually due to VPI, fistula, or it could be a mislearning, a child that is normal. He doesn't have any structural defect, but he has a mislearning way. It's phoneme specific. Certain sounds, he produced it with that are hypernasal. However, hyponasality, this is the opposite. There's not enough nasal resonance. And this happens with ENT causes usually as adenoids, nasal congestion or obstruction when we have common cold, or even with mid-face protrusion affecting the size of the pharynx or nasal cavity. And this is common with cleft lip and palate. Okay, how do we distinguish between hypernasality and hyponasality? We usually use sentences with oral sounds and nasal sounds. Okay, for example, with the nasal sounds, we use a sentence with the sound ma, and if the child utters the ma, ba, then he has hyponasality. For example, mama bitnayim manal, he would say mama bitnayim manal, he would say baba bitnayim manal. It's pronounced ba. On the other hand, hypernasality with the ba sound, which is a high pressure sound, this is uttered as a ma. Baba bil'ab bakura, he will say it mama milam kura, as a ma. Okay, there's also the AI test, and this distinguishes between hyper and hyponasality. We let the patient say AI, 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 and we occlude his nose. And if there is a change in the resonance, then this is hypernasality. Cul-de-sac, of course, I think most of us know the causes. There is resonation in a cavity, either the oral or pharyngeal or nasal cavity, but there is no exit to this resonation. There is a blockage. In the oral cul-de-sac, this may be due to microstomia, example like a microstomia where there is small mouth and there is a mumbling sound. In the nasal, this may happen in VPI and nasal obstruction and other patients with craniofacial anomalies. However, in the pharyngeal cul-de-sac, it sounds like there's a potato in the mouth due to an enlarged tonsil or nasopharyngeal mass. Another parameter that we have to comment on is the nasal emission. Is this nasal emission, is it audible with a straw only, or a listening tube, or is it in a form of a nasal rustle? Or is it consistent during the child is talking all the time, there is consistent nasal emission, or is it phoneme specific for certain phonemes? Phoneme is a letter, a sound, we say phoneme specific. And we comment on this degree of hypernasality, is it mild, moderate, or severe? We comment also on the speech sound errors, which sounds are affected. And we have to differentiate between obligatory errors and compensatory errors. This is very important because once there is an obligatory errors is due to a structural anomaly. Okay, structural anomaly, either in the palate, in the velopharyngeal dysfunction, or in the dentition or malocclusion. If we have a problem with these two issues, then these errors could not be corrected by speech therapy. First, we need surgery, and then we need to correct these speech errors. But compensatory errors, these are errors which the patient had due to this velopharyngeal insufficiency, and even after the surgery, these errors are still persisting because the child has been used to utter these sounds for a long time with this way. And these errors are corrected by speech. When there is velopharyngeal insufficiency, there's no closure at the velopharyngeal valve. Okay, so the compensatory errors, there are closures in other places. The closure may be at the glottal area, okay, performing a glottal stop. For example, the child, instead of saying ka, he says ah. It may be pharyngeal fricative. Instead of saying s, sh, he says okay. It could be a pharyngeal stop. It could be a glottal fricative. Instead of saying ka, he says ha. And it could be a posterior nasal fricative, also a sound that sounds like a nasal rustle. So all these compensatory errors after surgery could be corrected by speech therapy. Okay, and these speech sound placement errors, after being detected, they affect the speech and intelligibility. If speech is usually understood all the time and is within normal limits, then that is fine and okay. If it's occasionally hard to understand, he has this is mild. If it's often hard to understand, this is moderate. And if it's severe, most of the time the child is not understood, then we consider it a severe form of speech intelligibility. Okay, so I just wanted to present, this is one of our star patients. She's called Epigale, and she had performed. Is there sound? صوت. صوت.
33 علي راح يلعب كورة.
علي راح يلعب كورة.
كمال لابس كيك.
كمال لابس كيك.
33
33
33
33
جدو جاب جاتوه.
جدو جاب جاتوه.
بابا بيلعب بالكورة.
بابا بيلعب بالكورة.
سامي شاف فستان سمسم.
سامي شاف فستان سمسم.
Okay, Epigale had repaired the left lip and palate, primary repair, by Dr. Mamdouh Abul Hassan. Okay, and we can see here that her speech is almost perfect. There's no hypernasality, no speech errors. So I'll show you another example of a child that has a big problem with speech. This is Asim. He has repaired bilateral lip and palate. He had primary repair, and he is waiting for a secondary repair now. Listen to his speech. He has, of course, hypernasality. He has multiple speech errors. And another big problem that he has is the malocclusion. See how he's protruding his tongue. The tongue tip is supposed to touch the lingualveolar ridge in some sounds, but he couldn't because of this class 3 malocclusion. So listen to his speech.
Baba. 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 Ba. Ta ta ta. Ta ta ta. Da da da. Ka ka ka. Ka ka ka. Ga ga ga. Sa sa sa. Sha sha sha.
Okay, we heard glottal stops. We heard pharyngeal fricatives, hypernasality, and you could see the tongue all the time. Sorry. Intraoral examination, of course, I'll go through it quickly. We comment on the palatal mobility, lateropharyngeal wall mobility, any structural anomalies like submucous cleft, as we can see, any oral nasal fistulas, and the size and place of fistula has an important role or important effect on speech. We have to comment whether it's affecting or not. If it's a small fistula and anterior, usually there's no effect on speech. But if it's posterior and a large fistula, this has an effect. We comment on the tonsils, tongue, lip, facial muscles. Dental anomalies, of course, مش هتكلم بقى maxillofacial, I'll not talk about the dental anomalies. And malocclusion, whether it's class 1, 2, or 3. Okay? Now, one of the important or best tools that we use for confirming our diagnosis is nasopharyngoscopy. And this is an endoscopic evaluation that, by this evaluation, we comment on two things: the structure of the velopharyngeal valve and the function. Nasopharyngoscopy is usually tolerable by the patient, relatively tolerable. It allows direct visualization of the velopharyngeal parts. It allows examination during connected speech. It formulates the appropriate form of intervention, whether this patient needs speech therapy or further surgical intervention, and what sort of surgical intervention is done, decision about the best surgery that can be used. So this is the scenery of the nasopharyngoscopy. We can see this is the endoscopy. Okay. The endoscopy, this is the camera, a mic, and here, sorry, the child is sitting on the lap of his father, her father, and after convincing the child. Nasopharyngoscopy is usually done at the age of 3 years. We need connected speech, and we use, tell them speech samples, either syllables, repetitive syllables, pa, 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 ta, 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 da, 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 during examination, or sentences. These are English sentences, but of course we have our Arabic sentences. We let the patient count from 1 to 10, 60 to 70, connected speech, and we comment on the findings, either, as I said, the velopharyngeal closure and the gap. The patterns of velopharyngeal closure are numerous: coronal, sagittal, or circular. Coronal, this is the anteroposterior movement is more, velar movement is more. Sagittal, we have the lateral pharyngeal walls moving more. Circular, all the structures, either lateral or anteroposterior structures, are moving to the same level. And we may have a pattern, circular movements with a Pasavan ridge. So this is the normal structure that we see with... اديني بس 5 دقايق معلش. 5 more minutes, please. Okay. We can see here is the velopharyngeal valve. We see it from the top. This is the velum. This is the posterior pharyngeal wall, and these are the lateral pharyngeal wall. This is the normal velopharyngeal closure. We can see a complete anteroposterior closure.
Pa, 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 pa.
Okay, the next one. This is Gannet Abdeshafi. She has velopharyngeal incompetence, hypernasality, and she needs secondary repair. So first we'll listen to her speech, and then we'll see her nasopharyngoscopy quickly. بابا بيلعب بالكورة. 33. كمال لابس كيكي. كمال لابس كيكي. Glottal articulation, pharyngeal fricatives. Okay, this is her nasopharyngoscopy. We can see a wide gap here. Okay. This is another child with also a velopharyngeal incompetence. Also, he has a very wide gap. He has a wide gap with, you can see the Pasavan ridge posteriorly. Palate is still clifted.
علي راح يلعب كورة.
Okay.
بس أنا هو بس هو.
The gaps, either we find small gaps, medium gaps, large gaps. We can see a pharyngeal flap if that was done as a procedure. And finally, we can, after Dr. Mamdouh sends us the cases and nasopharyngoscopies, as a teamwork, we discuss together what is the surgery that should be done. And there are many options. I'm not going to talk about the type of procedure, but just some examples. If we have a small gap, this could have, the patient may benefit from pharyngeal augmentation. If there's a narrow coronal gap or submucous furlozeplasty would be an option. Central gap or large gap may be pharyngeal flaps, but I'm against pharyngeal flaps, and Dr. Mamdouh is also against the pharyngeal flaps. It's a static way, and usually there's no much benefit. And sphincter pharyngoplasty is an option for unilateral and bilateral. But this technique has been done since I've been working with Dr. Mamdouh for about 2 years, since I joined Smile Train program. The technique is done by Dr. Robert Mann and Dr. Mamdouh, doing furlough with buccal flaps. And this, of course, this technique results in velar lengthening. It could be used in primary cleft repair, secondary cleft repair. It's appropriate for all sizes, small, medium, or large, all shapes, pharyngeal patterns, either circular, coronal, or sagittal, all locations, central or lateral. However, this is the closest to the normal physiology of the velopharyngeal function. So, assessment should be done as early as possible. Speech evaluation is very important to detect the method of treatment, and nasopharyngoscopy is the best tool. Okay, thank you.
Thank you very much, Dr. Elamoudi. That was very thorough, and I really appreciate it. I do have a question for you later, I'll ask. I hope I can remember it. Okay, so the ages that you used as your age ranges for, when the brain is most malleable and that sort of thing, that's based on cleft children, or is that based on normal children without clefts?
It's the same, either normal or cleft. The brain plasticity is usually, the best brain plasticity is the first 5 years of life. And the most sensitive period is the first 3 years of life. But to consider the brain plasticity up to 7, brain plasticity is fine for learning. That's why I was telling you yesterday that when we usually get children that are 10 and 11 years or 12 years, we take a lot of effort to correct their speech errors because they're usually used to uttering these speech errors for a long period of time.
Thank you. A great pleasure here to introduce Tarek El-Fahar, who's going to talk about, and I can't see your talk up there, but he's going to talk about VPD treatment and how to surgically correct it.
Okay, I'm Tarek Abdel Fattah. I'm an otolaryngology head and neck surgery consultant at the Hearing and Speech Institute. And I have an announcement to make at the beginning of my speech that this is the most important lecture in this course. And I'm so confident to say that. This is the most important lecture in this course. And because this is the most important lecture of this course, I'm going to start my lecture by talking about the most important person in this course. You may think I'm going to talk about Dr. Robert, Dr. Mahmoud Fawzi, Dr. Mamdouh, Dr. Percy, but I'm going to talk logically about the bayan who's going to give the most important lecture. So I'm going to talk about myself. And I'm going to talk about my, let's say like a journey in VBI surgery. So it started in 2016. I work in the Hearing and Speech Institute. And at my institute, we have too many cases of VBI. I didn't know anything about it at that time, so I wanted to see somebody who can teach me something about it. I heard that Dr. Ann Kammer she's one of the best speech language pathologists in the world. She's coming to Mansoura University. I went there, attended the course. Later on, there was another course at the Cairo Cleft Center by Dr. Mamdouh. So Dr. Mahmoud Fawzi asked Dr. Mamdouh that I would give a lecture about VBI at that course. So if I'm going to talk about important people, I would like to talk about Dr. Mahmoud Fawzi. He's my mentor and my dear friend and my elder brother. And as I always talk about Dr. Mahmoud, when you see Dr. Mahmoud performing surgery, you get this very contradictory feeling that you are amazed. He's a brilliant surgeon. And when he does surgery, he doesn't do it like a surgeon. He do it like a painter. So you can spend 3 hours watching Dr. Mahmoud doing a total laryngectomy in a bloodless field, And then you feel so amazed and great about yourself. And at the end, just at the end of the surgery, you start to feel very low because you realize you can never make it this way. And the second man I want to talk about is Dr. Mamdouh. Dr. Mamdouh is all about cleft for me. We are all here because of Dr. Mamdouh. He's not only a brilliant cleft surgeon, but he's a very good person. And he is the one who can sit humbly and see others rising above just around him, and he doesn't feel any bad about it. And these are rare people. I owe too much to Dr. Mahmoud and Dr. Mamdouh. And then in 2016, I met Dr. Brian Summerlad. I saw his technique about the radical muscle repair. It was, for me, something that I could cope with very easily because he used the microscope and an ENT surgeon. We like using microscopes. I liked so much to see the elevator muscle itself, so I started doing radical muscle repairs. And then I met him a lot. Then in 2017, I met Dr. Lucy. He is a very elegant person, and he elegantly showed us how to perform the Furlow Z-plasty, which I feared to do before. So I started performing Furlow Z-plasty. And then at 2020, I met Dr. Robert Mann. And the moment this guy went to the stage, I hated him because he's a plastic surgeon, and we ENT surgeons don't like plastic surgeons. We deal with mucus and pus, and we do the low-priced tonsillectomies. And plastic surgeons will go and do deal with like fancy ladies who want breast and butt augmentations. So we don't like plastic surgeons. But when Dr. Robert Mann gave his first talk, he talked about his technique and his philosophy of reconstructing the palate. And the idea was so brilliant and so into the mind that I thought, why didn't anybody think about the palate this way? It's not just a gap that I want to fill, but there is a missed tissue that I want to add tissue to it. And he talked about using the buccinator flap. And so I started to like him a little bit. And then he gave the second talk about how to treat VBI. And he said, I'm a plastic surgeon, and what I think about is that we want to have a second stage. I want to have always a backup plan. So I thought to myself, this is the way I want to treat VBI. I want to reconstruct the Wheeler mechanism, and I always want to have a backup plan. And then since then, I started to love him and never stopped loving him since. So again, this is the most important lecture of this course. This is why it's the most important lecture, because it deals with the most important structure. A cleft is not just a gap that needs to be closed, but it is a dynamic structure that needs to be reconstructed. And the literature says that it is about 5 to 36% of cleft, rebirth clefts will have VBI. That means whatever type of a surgeon you are, whatever competent you are, you're going to face it. So this is a very important topic. When you are faced with this problem, you are asking yourself, when I'm going to interfere with a child with VBI? So this child must have connected speech, the ability to cooperate with you, and to have an adequate airway. This is usually around the age of 3 to 5. So the limit, the least age that you will deal with a patient for VBI is 3 to 5 years. And early intervention is a must, because this is the critical period of brain development. And the consequences of waiting too long are too much. The correction of misarticulations will take longer time with speech therapist. The prognosis will be bad, and it can affect the social and the emotional life of the child dramatically. So you don't want to wait. You should start dealing with VBI as young as possible. The youngest is between 3 and 5 years. And then you are faced with the plethora of surgeries that you can do. You can do a pharyngeal flap, different techniques, sphincter pharyngoplasty, different techniques, Furlow Z-plasty, plus or minus buccinator flap, reconstruction of the muscle sling. If you do it with your loops, you call it intervallar veloplasty. If you do it with the microscope, it's called radical muscle repair. You have palatal lengthening procedures with double buccinator flaps, posterior pharyngeal wall augmentation by different things, fat, bone, cartilage, alloderm. You have functional palatal suspension, and you have combination of different techniques. You can do furlough with a buccinator. You can do double buccinator with the functional palatal suspension. You can do a furlough with a sphincter pharyngoplasty. There are too many surgeries. So I'm going to touch a little bit about the these surgical procedures, and then we will move on. So the first procedure is the pharyngeal flap. And this video will show us the Hogan type of pharyngeal flap. You do a midline incision. You just incise your cleft. You design your flap. This is a superiorly based myomucosa flap of the superior constrictor muscle. Then you connect the two dots, the two lines together, and then you raise your flap upwards from the prevertebral fascia. And then you close the donor site. And then you will do two nasal lining flaps. These flaps are going to cover the undersurface of your pharyngeal flap so that the flap will not narrow in size and be lost. And this step is considered a very essential step of the Hogan technique. Then you have your flap inset inside of the palate as high up as possible, usually to the first cervical vertebrae. You pass a catheter so that you can check that the port is not too narrow so that the child would not have obstructive sleep apnea afterwards. The stitch at the tip is very important because it's going to anchor your flap to the soft palate. And then you will put your two nasal lining flaps on both sides to cover the undersurface of the pharyngeal flap. And then simply you are going to close the first incision that you made. Okay, there is another technique that you can do this, much easier technique. This is called the fish mouse technique, when you just lift the soft palate, do an incision on its undersurface, raise the flap, suture it to the soft palate. This is an MRI view of the pharyngeal flap. A pharyngeal flap is just a static bridge between the posterior pharyngeal wall and the soft palate. And if nobody have seen it before, this is how it looks during examination. If you are doing a nasal endoscopy, this is the flap, and these are the two lateral ports closed during speech. The second technique is the sphincter pharyngoplasty. You just simply raise two flaps from the palatopharyngeus muscle and make an incision on the posterior pharyngeal wall, connect the two flaps together. And this is how we do it. You inject on the posterior pharyngeal wall and inject in the soft palate. You make an incision in the soft palate, divide it into two parts. Then you will get your flap. This is the palatopharyngeus and part of the superior constrictor with it on one side. This is the palatopharyngeus and the superior constrictor on the other side. So these are the two flaps, and this is the midline part of the pharyngeal mucosa. And then you will make an incision in the posterior pharyngeal wall as high up as possible, just underneath of the adenoid tissue. Only mucosa, not the muscle. And then you will raise your flaps together and suture them in the midline. Now I'm closing the donor site. We are looking from beneath. This is the flap on one side, and this is the flap from the other side. Some would put the flaps overlapping, and some will put the flaps head to head. It doesn't make a difference. There's too many talking about this type of procedure, that sphincter pharyngoplasty is a dynamic procedure. Actually, I believe it is not, and these muscles do not move. It creates only a bump, a rope bump in the back of the posterior pharyngeal wall, so that it makes it easier for the soft palate to move backwards and touch the posterior pharyngeal wall. And this is how it looks at the end of the procedure. The Furler-Zooplasty, you create two Z-plasties, one on the oral side, one on the nasal side. You start by injection. You freshen the uvula. You raise your first flap. This is the left-sided myomucosal flap. This is the flap which contains the levator. On the other side, this is only mucosa flap. You cut your flap, move it backwards. You cut the oral mucosa flap and raise it upwards. You do the midline incision. And then you have your two lateral cuts so that the whole palate is divided into 4 flaps. Now I want to know if the flaps are going to be okay. Now I reconstruct the uvula. Take the posterior based right-sided myomucosa flap to the left side, and then the mucosa only flap from the left side to the right side. By this way, we have reconstructed the nasal side of the soft palate. Then we will reconstruct the oral side by moving the myomucosa flap from the left side to the right side. Now we have reconstructed the levator muscle sling by overlapping the muscles from both sides, and then the mucosa only flap. And this is how it looks. This is at the beginning, this is at the end of the procedure. Now the radical muscle repair. This is a previously repaired cleft. So you inject, you divide only the mucosa on the oral side. You elevate the mucosa of the oral side and try to dissect. This is of course done under the microscope. You dissect the levator muscle and the palatal muscles as a whole, as a bulk. Usually you will see the levator muscle at the undersurface of this bulk of muscles. Then you will reconstruct the levator muscle sling, push the muscles backward in their right position. And then you will close the oral side of the mucosa. The double buccinator flap starts by marking the punctum for the parotid duct injection. Do the same on the other side. And then you will inject the soft palate. A curvilinear incision between the soft and hard palate. You detach all the muscles from the posterior end of the hard palate and relax the muscles. Let them put themselves backwards to where they should be. Then you take your buccinator myomucosa flap. I like doing this with the scissors. Dr. Mamdouh liked to do it with the Bovie. You have to be very meticulous in elevating the flap. Try not to go beyond the fascia so that the fat will not protrude. This is the facial artery. You have to take care of this artery, of course, and not to damage it. And this is, you test that the flap can reach to the opposite side. Then you take the flap from the other side. It's the same technique. You just raise the flap, take care of the facial artery, and then test that the flap can go to the other side. And then one flap goes to the nasal side, so it will be the nasal lining flap. and the other flap will cover it so that it will be on the other side. So sometimes we call it the sandwich flaps because there are two flaps sandwiched together. And then you will close the donor site lightly. And this is how it looks at the end of the procedure. There is another procedure called the function palate suspension described by Dr. Mann. This is not a pharyngeal flap. It's just a very narrow and small flap from the posterior pharyngeal wall that only suspends the previously reconstructed double sandwich flaps to the posterior pharyngeal wall. It just holds the soft palate backwards so that it can move easily. And fat augmentation, you harvest the fat like any plastic surgery would do. Then you do stab incisions in the posterior pharyngeal wall, just a few millimeters below the adenoid. Then you will inject your fat so that it forms a bulge in the posterior pharyngeal wall. And then you will inject the fat in the back of the soft palate. And this is how it looks, the fat in the soft palate and the fat in the posterior pharyngeal wall. Now we come to the most important question. We have seen all these procedures. Now how I'm going to choose. Usually there was a debate. Some surgeons will prefer pharyngeal flaps. Others will do a sphincter pharyngoplasty. For years, these were only the things that surgeons would do for VBI. But later on, they start thinking about types of closure, as Dr. Iman said. They say if you see this type of closure, just do this type of procedure. If you see this type of closure, do this type of procedure. And others who rely on the video fluoroscopy would say you have to comment on the closure ratio, and they have so sophisticated numbers. If you see this type of number, you just do this procedure. I'd like to keep things simple. And I do believe now that we are moving from the pharyngeal procedures that use static flaps and distorts the anatomy into a more functional procedures that restores the normal function of the palate or the speech engine, and we should always have a multiple backup plans. So this is the protocol that I suggest. I start by doing nasal endoscopy. If there is a small gap, I would do fat augmentation. If there is any type of gap, small, medium, large, short palate, long palate, I would redo palatoplasty with furlough, specifically if there is a midline scar, and if I'm not the one who did the initial surgery, and then send the patient for speech therapy for about 6 months. And then if it fails, the patient comes back again, I would do nasal endoscopy. If I see a very small gap, I will do fat augmentation again. And if I see any other gap, I will do a double buccinator flap to push the soft palate backwards. And then I would send the patient again for speech therapy. If the patient comes again, so there is no way my augmentations and work on the palate is not sufficient, so I would do nasal endoscopy. If there is a very small gap, I would do fat augmentation. If there is any other gap, I have to do a pharyngeal procedure, so I would comment on the nasal endoscopy. If it is a sagittal closure, that means the soft palate is not moving well, I will do a pharyngeal flap or a functional palatal suspension. If it is a coronal type of closure, I would do a sphincter pharyngoplasty, and then I would send the patient for speech therapy. If this again fails, there is no way. This is a severely scarred palate, it's very short or immobile palate, and the only hope for this patient is by palatal lift or the speech bulb. And I think by doing this type of procedures, going in a sequential manner, usually you can give good results to your patients. And thank you.
Thank you so much, Tarek. That was fantastic. Absolutely fantastic. I think that's probably the best review of all the operations that can be done for VPD I've ever heard, period. That's the best. Thank you so much. Which leads me to the question, does anybody want to hear me talk? Because otherwise we could go home, because he said everything I'm going to say. All right, we'll keep it short. I will just go along real quickly, and you can feel free to ask questions while I'm talking, and we'll just get through it and get everybody a little bit of rest. You guys have been super workers here. You had me for 20. Is that okay? Something like that. All right, I need to get to. This can go back to, yeah, that's good. And I don't need that for this. No sound. All right. Well, once again, thank you to my very good friend Mahatma for having me come back again, and all my other friends that I have and new friends we've made. And we'll wind up this session with the anatomic cleft restoration philosophy in VPD. This is taken on quicker than I thought it would around the world. We are looking at this as being now what you do as your first go-to rather than jump to a pharyngeal flap, which I think is extremely exciting. Yeah, and that's not working. Okay, we'll put that away. So to me, when I've said it over and over again, is the closer we can get to normal anatomy, the better our patients' lives are going to be. Their form follows function. Everything should be that way. How do we get there? Oh, look at that. There's a lot of other people who are using this, and they're starting to innovate, and it's extremely exciting. So people around the world, this is Stanford University. This is taking and finding out there's a lot of deficient tissue there. And he comes up with a beautiful repair using double buccal flaps, making them their own. This is Jordan Steinberg in Florida. He used to be at Johns Hopkins. He's now chief of Nicholas Children's Hospital, adding buccal flaps to take care of those very complicated clefts. This is Joe Losi that we've just talked about, and he's added his own shape to. He called me up one day and, Bob, have you ever done this pattern? I said, no. I have done lots of patterns. I haven't done that one, Joe. So off and running. Cam Patel, Washington University, he's doing his thing. Multiple friends in Smile Train, I'll be seeing them in January, and they're going to teach me a lot. I'm going to guarantee you that. Jadeep does the thinnest pharyngeal flap I've ever seen, and Tarek, yours is doing the thickest I've ever seen. So we're going to talk a little bit about that. I'm not sure you need to, you're somewhere in between, but if you're getting great results, then that I want to hear how that one does. Marwa here, she's been doing these for quite a while. Joe Napoli in Children's Hospital of Philadelphia. This is just people that have sent me these. He showed the growth. This is a group in Nigeria. And there's just lots and lots of universities and centers that are now embracing these prospects. So Egypt's ahead of the curve, but you're not alone. And there's room. So I want all of you, if you'd be so kind, if you're starting to use buccal flaps and you're having good success, please send me the pictures of what they look like. So I know that I can say, oh, there's verification that they're doing it. And I'd like to be able to then consider you a faculty as continuing to teach others. On my mind, I think every single day of the thousands of kids, a baby born every 3 minutes, I sure would like to see them have the successes that you are creating rather than what we've really been doing for so many years. So if you do that, it'd be a big help, because I think when you see how many people are changing, it makes you confident that you can take that leap. Because we talked all day long about, I'm not sure I can do that. Well, the reason we're not sure is because we are not confident. There's nothing more confident than other people saying, I had great results, I had great results. You don't need a p-value for great results. So I think that's what I'd really appreciate if you could do that. You've got my number, and it'll be on. I'll leave it on at the end for anybody who wants to get in touch with me. The buckle flap helped me a lot. This is how I've raised a buckle flap. The key for me, I'll talk about what I think makes the buckle flap work the best. One of the things we haven't talking about is delaying a buckle flap. It's just another flap. You can delay it. If you're concerned about the vascularity and you've got a particular issue, you can delay the buckle flap by just incising around it if you're doing another procedure or whatever. And then it's going to be even more robust. But I go right just behind the orbicularis oris muscle and pop through that when the fibers are going linear up and down towards the commissure until I see the white fat. Tarek goes a little bit deeper. That's fine. I stay right on the muscle. I take everything off the muscle, and I actually leave fibers on the cheek. And in the article in 2011, I said I was taking about 80%. I probably take 95% of the muscle in the infants, and I take about 80% in the older kids. And you'll see the difference between this dissection and the older kids. But you can see the muscle fiber. I kind of pick a muscle fiber I like, and I just kind of slowly pick at it until I get a nice, smooth situation. I'd love to tell you I was doing this buckle flap, but I'm not. This is one of my partner's first buckle flaps, so I'm the Q-tip here. So, but it goes to show that this is the very first buckle flap, that it can be done very nicely right away. It doesn't have a real long learning curve. You don't have to be afraid of it. Am I right about that, Tarek? You're comfortable with that, right? If you do cut into the muscle, it will bleed a little bit more than the fat, but if you're in the fat, you do have to look out for the artery, and then it bleeds a lot. So you don't want to get there. And I'd say 1 in 10 buckle flaps I buzz. The rest of the time, not so much. I use hydrodissection, so I use a really dilute local, 1 to 4 or 1 to 800,000 epinephrine. I just wait 10 to 20 minutes. I'll inject it while I'm doing my dissection on the palate. By that time, it's really nice and white, and you're ready to go. But you can see I just kind of pull it along. Now, I also want to point out that this is an infant. You can see it's a bilateral cleft there. You can see the prolabium. And we're not that deep in children. They're just not that deep in the mouth. So it's a much easier dissection here than it is when you see the next one that we're going to show you. So I think that's a good for that. So how do you maximize your success with a buccal flap? Well, there's 3 parts, 1, 2, and 3. 1 is the muscle where you're getting the microcirculation from the capillary that runs through all the muscle fibers. 2 is where you're getting kind of a little bit of muscle fibers, and 3, it's a random flap at the tip. And random flaps, are going to be height and base the same, and this clearly is not that. So you can get a longer flap, but as I'm going to show you later, it's much different in the older kids. Use as short a flap as will do the job. Make it as wide in the base as possible. People say, how wide do I make it? I go right up to the retromolar on either side. And part of that is if you've ever worked, like these flaps are like working with worms. They go all over the place. And you can easily make one too short. If you make one that's too wide, a little shorter than you want, narrower than you wanted, you're still okay. But if you start too narrow and you make it too narrow, you've got nothing. So I always make it wide. You notice it's wider in the middle. If you take off the muscle retinacular structures, which I'll show you, that gray structure, I just tease it right off. That's a fibrous structure that kind of supports the fibers. If you take it off, when you stretch it, it now straightens out, but you've gained the muscle fibers right to the edge. In my heart, I don't have a vascular injection. I didn't do the scientific study to show it, but it just makes sense that it gives you better blood supply, so that's what I do. And muscles right to the edge then. So the other reason I take off the fat is it makes the pedicle base kind of bulky if you have that. And this just lets me tuck it a little bit easier. So in the treatment of VPD, of the things I've written on primary palate, secondary palate, and fistula management, we're going to talk about this, but if I think about where to use them, the buccal flaps, it's good, better, best. So you get dividends. It's like a bank when you use them as primary, and we've talked about that today. But if you do have somebody comes in, it's my go-to for reconstructing them. Are they safe? I think they're safe. My first 329 patients, I just grabbed my book that has all the patients, and after 329 I said I'm done. That was 583 flaps. That's enough. So the complication rates associated with the buccal flaps in those patients was 1.4%. In the first 70 patients with VPD treatments, it was 140 flaps. It was 5.7%. That's pretty significant. So another thing that tells me it's easier to do in the babies and better viability. How to use them? Well, this is a speech engine. That's what I want to reconstruct. That's what I want to see. I don't want to use pharyngeal flaps. And in this, we always used to jump right to your favorite. It's whatever. I'm a sphincter guy. I'm a pharyngeal flap guy. I think it's hilarious. But now it's a repalatoplasty, and that's not, for me, a Z-plasty. That means I'm moving my buccal flap around, and a palatal lengthening, and then a suspension, as Tarek said so beautifully. And only then do I get to this. And that is essentially never. So in '88, I basically took the no-touch repair and started using it, and I called it the double opposing buccal flap because it kind of went with the Z-plasty thing. And it's been described, it's more anatomic, I think, than pharyngeal flaps, which is just a good thing. So you've got your straight line, you've got your palate doesn't have good movement, you've got the scars on the side from the contractures, you've got the stress you can see in here that is, these just aren't, they're supposed to be a soft curve, not these straight lines. In a curvilinear, and then make sure to square it. And it just goes back to where it wants to be. Per Hall, who I did a workshop with at Edinburgh, he says when he does it, the palate goes, it's right where it should be. I stole it from him. And you do get a large movement backwards. It's not a setback. It wants to go there. We're not pushing it back. I guess we're setting it back by releasing it, but we're not pushing it. Once you have it there, then it's just, like you said, it's just a matter of leaving a cuff on the nasal side so it's easy to repair. If there's lack of cohesion, you can fix that, and I'll show you one of those. This is cartoon, just to show the contours. I jump it over this. It gives me the flexibility of moving it if I want to. It gives me the flexibility if I lose part of it, I can flip this one back again. So it just, a lot of reasons I do it that way. On this side, it always goes forward like that. So it ends up like that. Easy closure. I won't go through that. We already talked about it. After orthognathic surgery, here is the child who lost her speech. You release it. Same way. You're going to make it. There's nicely squared so the flap can slide in easily. Parotid duct, very important. It sets in just easy. And then tuck it the corners. If you need a splint, which is probably about 30% of the time, you can. There's lots of ways to do that. We can talk about that later. So that's what it looks like a year later. If you've got good muscles, it flattens out. If it doesn't, it might take years to do it. If you have a child with VCF, it's going to take even longer. And you can see it's already expanded a 0.5 centimeter. Here's one that didn't flatten out very well, but now a couple of years later starting to flatten out a little bit. But this area now is unscarred, which is important for movement of the mandible. So this is a palatal lengthening procedure, and I'm going to draw out so it looks like it's actually a palatal no touch here. So there, I made it a palate. So basically, if you just cut that palate off and move it back, you've got a no touch or a palatal lengthening. The other blue marks are where the relaxing incisions, just so I know where the blood supply has been interrupted. The no touch is easier because it's obviously anytime you're working in an area where there's no scar tissue. And I'm very rarely bovie, but you can see here you're boving a lot. Otherwise, you can't do a video because it's just that scar ooze. And you separate it, you cut through it, and when you do, everything falls back again. Now in this one, you can see the lack of cohesion of the levator right in the middle here. In just a second, when I'll move these together, you can see I'm going to need to tighten those muscles up to make it right. So this is a different view of raising the buccal flap, so I'll stay with this for just a second so you can see how much longer the flap is in this much older child. It may be a little wider, but it's dramatically longer. It's at least 5.5 centimeters long. And the base of it is really, 12 compared to, it's literally twice. 5.5 to 3.5. So I pop right through it, and now I just want you to look at how much muscle fiber I'm actually leaving still on the cheek. So you won't really see any fat going through. So the older they are, the more muscle I leave on the cheek, because I think the blood supply is only supporting the mucosa, and if you have too much out here, it's really not helping. It's just creating a bulk that can cause the venous return not to be as good. I've never lost flaps to the same degree in the infants as I have in the adults and older kids. And it's not very many. I mean, I lost like 5, and there's only half of those. So they're very, very safe. See how it just lays in there. And then just put the other one on. We'll just skip through this because we saw that other one. And that's it. So repalatoplasty is when you've already used a buccal flap and you just move it. If it's attached to the cheek, it's super easy, obviously. Otherwise, you just do it like a tumbling flap and just leave a base here, take a good chunk out of this, release it, and move it back again. So you just pick it up, put it back, and there you go. Now, if you ask me, do I have a series of 100 of this? No, because those are kids who I've added buccal flaps to their Z-plasties, and I only have 6.6% of those that need secondary speech surgery, so there's not very many. But this would be one of the things I would do. So the palatal suspension, once again, how many of that? There's 17 that I've done. I think I've done 25 now. But it's not a pharyngeal flap, but it is a pharyngeal flap because it's from the pharyngeal wall, but it hooks into the buccal flap to lengthen them and strengthen them by moving them upward. And it goes down to about a 2 to 3 millimeter area, so it's not going to be obstructive for speech. These are the diagrams. That's an hour-shaped unlined flap, a big fish mouth incision. Pop it through, sew it in. It's going to pull on the buccal flaps up and backward, and it's really worked out very nicely in the limited number that I've had to do. And once again, I use it in velocardiofacial syndrome. So this is a video of that. I just cut through it. And it's easier to do than a Heinz pharyngoplasty by far because you're looking right at the flap that you're working with. So there's your big hole. And once again, it kind of falls back a little bit. I thin out the buccal flaps if there's any scar tissue or any of the muscle that is atrophied. And then I take my pharyngeal flap and then I pull it through to the other side here. Now I sew it in place. And then I've got, I go to about halfway through the thickness of it so that I've really got good adhesion of the vellum to the buccal flaps. Close the nasal layer to the upper edge here, and then I close the oral layer. So there's the nasal layer closed. And there's the oral layer closed. These kids will stay overnight and then go home the next day. The kids, they're tolerated very, very well. So it's more anatomic, and I think it's a really good way to think about VPD. I really want to thank everybody for your hospitality. This is where I'm going back to. But right now I'm here, and I really appreciate it. That's my email. Please take a picture of it, and please stay in touch, okay? Now, questions for any of the people who have just given a lecture? Tarek? I already asked my question to Dr. Amin. Is there one after me? Yeah. You're kidding me. Yes. You're kidding me. There's one more? Yeah. No, the best is had for last. Thank you very much. I'd like to introduce our great friend and the chief here, Mamdouh Abu Hassan. I'm just kidding.
Yeah, no. First, I would like to thank Bob for his attendance. Actually, this guy is very busy, and we were actually blessed of having giving his time for us, because many places are asking for his help, and he travels all over the world. And but we have a special relationship with him, and he's part of our team actually. So he didn't think twice about coming back here. Okay. So it's gonna be like a repetition of 90% of what he said. Okay. So first, we are fighting about the naming of the procedure. I'm preferring the anatomical restoration cleft palate repair, calling it the arc repair. I think this is easier for all of us to remember it instead of having a long and the American way is having this shortcut. So I call it the arc repair, the anatomical restoration cleft palate repair. Just going through the anatomy, everybody's talking about the cleft palate is about a muscle repair, but it's in the literature. It's a musculomembranous structure, not a muscle only. And what is the tissue we are missing here? We are missing this tissue, what's called the tendon of the tensor palati or the tensor fascia or palatal aponeurosis, whatever you call it. In the cleft palate, you don't have only deficiency of the muscles, but also you have deficiency of the palatal fascia. This is my concept of the cleft palate repair. Mahmoud and everybody's talking about the reconstruction, the function, the dynamic, and the advantage of furlough of having lengthening, muscle reorientation, no burrowing, and you don't have to do a relaxing incision. I owe these guys a lot because they were my mentors and show me the roadmap into this repair. One of the problem of the furlough that you have always having a deficiency at the angle. Furlough is not an easy procedure. You have to learn it well. It adds the lengthening and reorientation, and surely it gives a better speech, but needs a training curve, and you need to train it in a place that practices it as a normal thing. It's as Mahmoud said in the beginning. It's very frustrating once you make your cut and you find everything splitting away, and you are always thinking, why I choose this profession, why I'm a surgeon, why I was born even today. It's sometimes you would like just the day would pass away. But if you think about the Nietzsche, Friedrich Nietzsche, that the snake who cannot cast his skin, who cannot change his skin, it will gonna be die. It will die. So it's the same thing about ideas. I was very strict to two-flap palatoplasty for a long time of my life, and I was about to die actually because I saw a lot of complication and speech problems. So I had to change, and I did that. I was happy that I was a student of this brilliant guy a few years ago. So it was the first presentation of, for me in the European Cleft Palate Craniofacial Association. We were stressing about this reconstruction of the fascia, and this is what we do. We do a clinical examination, speech evaluation, and we see how the gap wide is, and the closure, and the muscle mobility. I believe that if you have a fibrosed muscle, you should expect that the speech will not improve. So we prepare our best results when the closure is 2 out of 4 or 3 out of 4. This means that the patient will get back to normal, actually. So when you look at the previously repaired by 2 flap palatoplasties, most of these cases are mine, but very few are not mine. You see the muscles is well repaired. You have a small fistula, but the direction of the muscle fiber itself, it is reoriented anteriorly, and whatever the contraction, it will not function properly. Once you release, once you release the muscle, you see this is 2 centimeter, at least 1.5 or 2 centimeter relaxation without any suturing. And you have to fill this gap. You have to fill this gap. If you close the muscle, the mucosa, you can stretch that and close it, but you still have a 3-dimensional deficiency, and Joseph Lucy have showed in many presentations, he measured it, and it was 12 cubic centimeters. It fills with blood, hematoma, and mucus, and this will result in fibrosis, and this will bring the muscles back anteriorly. So we don't want to do that. So we fill it with a similar tissue, which is the buccinator. I did also another modification. I take a very long buccinator and I completely release the muscle on the right-hand side on the nasal layer and de-epithelialize part of the flap and tuck the muscle over here. I tried this side. This was the result of notification from my speech pathologist, Dr. Iman, that some of my patients that had a small gap post-operatively after doing the buccinator, the right side is usually the gap where it is the left side, because we dissect the muscle clearly on the left side on the oral layer, so we can see it and we are not afraid of anything. On the right hand side, it's nasal and deep, and we cannot see the vessels clearly, and we are afraid to extend the incision. So we had to fill this triangle, actually, and I feel very much confident now that we have a lot of muscles here, so the muscles on this side will not come back and stuck to the hard palate. So this should be a short video. I start marking the parotid duct by a suture. Actually, I take a suture just 2 millimeters below the parotid duct. Markings in our hand doesn't stay along the surgery. See how once you release the muscle from the hard palate, it's 1.5 centimeters. I take a very small mucosal triangle, actually. I don't like many hands in the surgery, so I just stay sutures. As a pediatric surgeon, we use a lot of stay sutures, so I'm accustomed to it. I don't want any hands. So once you release the other side, you see the muscles is relaxed in the back. We reorient it medially, do the nasal cut on the left-hand side, and reorient the muscle to the back. I raise the buccinator and I raise it thick, actually. I tunnel it because I find a lot of patients who bite on it if the patient, and as you see, it's a very long buccinator, so I remove part of the mucosa, and then all this muscular tissue is tucked into here. So we have extra 1 centimeter on the right-hand side. It is about 5 centimeter and about 2 centimeter wide. So this is one of the patients. This is the people. This one, I did a 2 flap palatoplasty actually 10 years before the surgery, and you can see this is the same line. And we have gained 2 centimeters. And what's impressive is the direction of the muscles, and now it's transverse. This is her video endoscopy. You see complete closure. Another case, a huge buccinator, and the muscles are extending to over here. See, you can here see the uvula or the end of the palate. Here you cannot see it actually. Another guy, the same thing. So people are talking about the buccinator morbidity, the having it a problem on the cheek or something. This is our primary cases actually, and we can show they are blowing balloon and we have no problem actually. And the buccinator is very good, nicely looking in there. So the tips and tricks. Intraoperative, you have to mark the parotid duct. You use a small mucosal triangles. I start by suturing the uvula first, disinserting the muscle from the hard palate before the cutting, and release the nasal mucosa of the bony attachment. No release incision and take a wide buccinator. This is the main concept. We take the muscle suture first, and we do not overstretch the mucosal flaps. We let the triangles relax it as much as we can, and we depend on the buccinator to take over the job. We restore the anatomy, the function, and for a long time, we are results for growth. We are doing our research now that we are taking for our primary cases. Sorry, you see different cases. We take an impression, and we are waiting for 5 years to see how the arch will change with growth. And this is what we get from our patient, that she can speak well. You can change the life of the patient, actually. This was a 16 years old girl that she was embarrassed to talk on the WhatsApp and the new. The efforts of our center actually have added not only to our patients locally. We were the first cleft center in Smile Train from 70 countries and more than 800 centers to propose to provide the service for ENT for completely free or out of charge. Actually, it was the work of Dr. Tariq here that he was not only, we were asking for it, he wrote the STX questions and assessment and follow-up for the patient. This was the work of Dr. Tariq actually. We started it in last February, and we are happy that this work have benefited children all over the world. So we're not only concentrating on the surgery, we are concentrating on the comprehensive cleft care all over the world. So thank you, Tariq, and thanks our team actually for this achievement. 2022 was a big achievement. And as Dr. Mann says, you spent your life, but you changed the life of your patient. And you always feel that you are part of their family and their happiness. This brother and sister, this girl, when she got married, her father sent us her photo in her celebration, and I was very happy. 2 or 3 years later, we thought that we finished. We did our work. The patient is looking fine, and she got married, and everything is okay. Her first child having a bilateral cleft lip and palate. So his uncle also having a bilateral cleft, and we're still doing his bone graft, and he's on the way. So we had this sign: when you feel that you have finished your work, it never ends. Cleft is part of your life, never ends. And I leave you with Abigail. Abigail is. Wait, we need the sound. عايزين صوت يا شباب. I didn't do her lip. I only repaired her palate. عايزين الصوت، هو مش متواصل. لا المفروض يطلع. هاتوا ناحيتي شمال.
Actually, جاي المايك المساواة. A B C D E F G H I J K L M N Q R S T U V W X Y Z.
Papa,
Papa,
Kaka,
Kaka,
CCC.
CCC. كمان لابس كده.
Thank you, Mom Dao. That was fantastic. I think what we're seeing, I think we're seeing an Egyptian arc here. I think this is innovation. This is when I say Joe Losi called me up and he was doing it slightly different. It's you're in the hybrid because it's different than what I do, but it's based on all the concepts.
Yep.
Absolutely amazing, and that's fantastic. So thank you so much. Opening for questions at this point in time, Adam.
Thank you. I was very lucky. I had Rob in Poland for 10 days. I made him doing the buckle procedure 10 times. Did I observe it correctly that you did one-sided buckle flap procedure?
Yep.
Okay. And when would you do that? I mean, what would be your criteria? And I would add another question. Do you still now and then use the ancient procedures, not buckle flap, or you just go 100% of them for buckle flaps?
I've been doing this for more than 5 years now. I haven't done a two-flap palatoplasty since then. When I started doing the Furlow Z plasties, I did it first in the secondary because I was a little afraid. But since I started doing it in the primary, even in submucous cleft, I would add a buccinator. There is a missing tissue called the palatal fascia. No one talks about it. It's a missing tissue, and we need to replace it. Replacing by stretching the mucosa on the oral and the nasal side is not enough. The muscles will come back and attach the muscle to the hard palate. And actually, if you see a previous patient with a furlough only, and you just release the muscles the same way as Dr. Mann said, you see the muscles going resting, even from the oral layer. Sometimes I don't even open the nasal layer. But once you release the muscles from the oral, from the back of the hard palate and from the nasal mucosa, you found the muscles, it's gapping. You find this line is turned into a hole, a big hole or an oval defect. This has to be filled, but filled by soft tissue. I have another theory, and I was talking to Bob about it, that the muscles that we replace the buccinator is not only aesthetic, it's a functional and gets innervated by the same nerve supply from the palatal muscles, and it acts as a kickstart when the muscles contract during talk, because it's during speaking the muscles contract quickly. It doesn't goes back completely to the resting position. The muscle elasticity keeps a little bit of the thickness of the muscle. So when you try to move another movement, it's already 10-20% ahead of its original place. So this is another unproved theory. It's observational rather than scientific work yet. But we are studying right now the results by speech, and the new things now is the MRI studies. And I think there's some suggestions of doing it to see the movement of the muscles dynamically. But still, this you cannot apply it until the child is 9 or 10 years. My children are still less than that. They are about 6 years now. So I'm waiting. We're still waiting for two things: these dynamic studies and also for the gross. I believe the arch of the patients, as you see, we've taken them primary before repairing even the palate. So we have these casts and we have these models, and we're going to do that for the same patients 10 years from now, and we'll see.
Thank you.
The second question. You said, do I use the vaccinator as a routine? Yeah, I use it as a routine in all my cases.
Yeah, but the question was one-sided.
Yeah, I still
Procedure.
use one-sided. Very, I don't say very rarely. Sometimes the very wide palate, you cannot close the nasal, so I use the double vaccinator as Dr. Mann explained. I use
Okay.
one for the, I always, those who started doing cleft always they have thinking that the fistula rate is 5 to 30% as Tarek showed, so you have to have a backup plan. The vaccinator was the main backup plan for any fistula in the palate, starting from the incisive foramen backwards. Using it for the primary, everyone says that you are burning all your backup plans. Sometimes when you get accustomed to use it, you will be encouraged, yes, to use it bilaterally because you try to get it right from the first start. If you listen to Dr. Mann several times, you have to get this engine, speech engine, in its proper position from the start. Yes, sometimes you might have a small fistulus, but you have the base of the flap, and you can rotate it and close it. And I did it in 2 cases actually now, out of 350 cases now.
But when you use like only one-sided buccal flap, so one surface is not covered, so you just leave it like that? And
No,
heals.
it's covered.
With what?
It's closed by the nasal layer. You mean
Later it grows, but at the end of the procedure, it's like raw surface, and you leave it like this?
no?
No.
You have a nasal closure by the by the left nasal layer of the furlough.
Oh, now I see. Okay.
Okay, so
No,
I
I
have
understood.
a nasal layer closure, but I have a thick muscle mucosal layer in between the hard palate and the muscles below.
Okay.
You're gonna see it.
Yeah, I'm gonna see. Yeah.
So when for me that would be a type 4 repair. So I completed my Z-plasty effectively on nasal closure, and on the oral side I still have a deficiency. And so as I was going through and learning to do this, I was doing some where I was just using one buccal flap on the oral side and got my Z-plasty closed. Others, I used one buccal flap on the nasal side and got the oral side closed. And as I worked more and more, I realized maybe I'm underestimating the tension. And then when we looked at the numbers of the large series, there wasn't a statistical difference, but the best percentage was when I used both buccal flaps. So then I started adding more tissue. And Joe Losi and Mamda they're both using double buccal flaps again when they think it's bigger. And then they're doing a little higher percentage of the single versions. And then when their data comes out, then we'll just see. And then, then the pooled kind of data will say, is it statistical? When do you really do it? My guess it's going to be based on the anatomy of the individual cases. When you've got the real hypoplastic areas, you have to use 2. There's not going to be no question. Then there's going to be that gray zone. Can we get by with one or do we need both? Question over here, Adam, if you'd be so kind.
Thank you, our masters, for your very impressive lectures about the buccal flap. But let me ask a question about a data dynamic
No, not
repair.
at all. No,
It's
it's
just
not. It's not.
a
It's-
volume repair.
Yeah,
So, what is your opinion about having non-functioning palate and pushing this palate back?
No.
Just lengthening the palate.
The palate still muscle. We're not damaging that. The buccinator muscle is not functional as an adjunct to make it more functional.
I mean, do you consider reopening this part and correcting the muscle in such cases?
If needed.
In the VPD cases, that's what you're saying?
Short palate.
Yes.
And then you, with VPI, and then you go for putting a double cheek flap or mymucosal flap to lengthen the palate. Do you consider adding to this some investigations before doing so you have a good functioning part of the palate, muscular part or not?
So when I first published this, my thought was, yes, exactly that. I was concerned that I had to have a certain degree of function to make this work. And so if you read that, I think it was like 7 millimeters was the deepest gap I thought that I could close. But what I found out, I was working with some PhD and physiology people, and we were talking about function of muscles. And I did a lot of work with people who were paralyzed, for example, and you know, the muscles were how they atrophied and what was going on, and pressure sores where the muscles are the first that get damaged. The last is the skin, and I'm saying, are those muscles fragile? And the answer is the muscles are not fragile at all, according to what I was taught. They were saying, no, the muscles can be wrapped in scar tissue for years and not functioning very well. And if you can free them up so that they're in a position where they can work in their normal function. In other words, I always say to parents, if my muscles are hooked up like this, but I'm supposed to shake your hand, we're going to be here a while. And so the answer is, I started not worrying about the gap. And I said, if those muscles are immobile palate, like the very first picture I showed, I go in and I release it. And as you release it, you can see the scar tissue that you're dealing with. And if there's a really bad scar tissue, that dissection turns into a radical muscle dissection, where I think Adam saw a couple of those, where I got the whole levator out, 99% of it, not entirely circumferential, but we could totally see the muscles, and you hook them together. And I found that those muscles, once they're in place, even though they hadn't moved well for years, started to function.
So you support readdressing muscle and the surgeries?
You are readdressing the muscle. You're always seeing it. And if you can't see it, you're looking through a couple fibers. And if it looks like it's got good cohesion, then you don't have to do anything. But if it's got scar tissue, then you're going to bring those muscles together. Yes, 100%.
Thank you.
أنا بس ممكن can I ask you for a favor? We can take a 5 minutes break now and just finish our lecture, our last session. You can ask a question, but to go and have dinner after that, instead of having a coffee break, then come back again. معلش هنبقى متعبين شوية إن إحنا هنرتاح بس 5 دقايق ونكمل الجلسة الأخيرة. إحنا عندنا 2 presentations إن شاء الله هنخلصهم على طول. Okay? Okay.
My question about detaching the base of the buccal flap. When to keep it attached? Dr. Mamdouh tunnel it and keep it attached, right?
The primary, I don't tunnel it. If the child have teeth, I would tunnel it. So in adults, I'm very, very well protective. I use dental block. They call it bite block. They put some acrylic on the last couple of molars, and I tunnel it. I have to use everything I have to protect this vaccinator. I don't know.
And when do you think to keep it attached, like?
Yeah, you want to cut it. You can cut it at any time after a month or so, but I only needed to cut it in a couple of patients.
Yeah, the nasal side that goes underneath, Ian Jackson did hundreds of those, and he said he never had to divide them. There is a micro fistula as it kind of tubes going through, so when you do divide it, you always see that. I just think, once again, if I'm there for other surgeries, I'll divide them. So if there's a bone graft coming up, you can do it then. Now that I stage my complete lips, so I'm doing lip repair, palatoplasty, nose repair, palatoplasty, lip repair. I'll divide the buccal flaps as long as everything looks like it's really good. If I've got a child who's hypotonic, I'm not going to divide them, because I may want to shift their position depending on that. And as I say, for the first 20 years, I was waiting until I would do the bone grafts. And with the VO2s, I would wait sometime down the road when they needed PE2s replaced or some dental work or something, and I pop in and divide it. The adults who show up years later, you literally, it's almost like a tongue tie. You could just put some numbing medicine in a topical or inject, and you cut it, and you don't even have to stitch it if you want to. And the older kids, if they bite it, I don't care. I never feel bad if I leave a country and kids have got buccal flaps sitting there, because it's not hurting them at all. And if it gets in their way of their teeth, they'll bite them. Do you have a question? Okay. Right there.
We are maybe very convinced with this flap, but anyway, my question can be a little bit. I prefer to ask it as a professor trying to convince me as a student. Like, please, can you tell us what is the complication of the donor side of this region? And did you ever get necrosis of this flap?
Yeah, you're going to get necrosis of anything you work on. So, but it's pretty rare. That's what I say. In the primaries, you're going to lose tips. You might lose a third. It'd be really rare that you lose a half of a flap. You're going to get little fistulas along the side, especially because you put this in, it's soft and it sits there. And if you're doing a VO2, you go to the front, you've got it completely closed, and now the kid has a wonderful toy. And they'll just take that flap and they'll pop a little hole through it, and the air's going through there. And at some point in time, when you're dividing the buccal flaps, you just open it up and close it again. And it's usually good by then, because the buccal flap is now more tough because it's in a different environment, because it's really not quite supposed to be on the hard palate, right? So you are going to get that. The complications I've had in the secondaries, I've had some half flap losses. I've had one almost 3/4 loss. I've had a couple part and part. I've never had to put a flap in to correct it. I haven't had a single kid that I had to go back and do secondary speech surgery on after it healed. So I obviously still had enough. No, let me rephrase that. I have done a couple times when what was the remnant of the cheek, I'd flip it back in. So then I kind of make up for some of the loss. And after I did that, I've not had to do it. But that's only 4 times I've ever had to do that. So when I reviewed the donor site, I reviewed my first 400 cases of buccal flaps, okay? 500, no, it was in that 505 series, 505 cases. One patient, I went in and she was a very dramatic child, and her orthodontic brace was irritating her. So I just did a little Z-plasty by that, and she was good to go. I mean, she love her to death. She's a great kid. We still stay in touch. She's about 22 now, but that's the only one I've had to do. If you read for the FAM flap, if you read that, which looks like a similar flap, but it's really quite different. And so Presbyd says close the donor area in layers. And then, but you got to remember, with that flap, you're only taking this much muscle. I'm taking this much muscle. So you do that, and you muscle to muscle. So when I first went to Europe, they were like, we don't like this at all. We're having way too many donor site problems, because they were trying to close that.
I've never seen a problem with the buccinator or any deformity or anything. And even in a couple of cases, the suture have been opened.
Yeah, they
and
just
I
hang
thought
like a
that-
string in there.
Yeah, and I thought that, I'm going to have a deformity even once ago. But I've never seen in more than 400 cases now any problem with the buccinator donor site. Yeah. And I proved, I had to put this picture with the babies blowing the balloon so that everybody sees that both sides are similar. There is no even lying or any even in under pressure or under stress, you see the muscle would show any deformity. It doesn't happen.
Like a tuba.
Yeah.
And you have to blow. If you've ever blown a tuba, you really have to blow. I mean, that's serious work. But I think the key is just to close the mucous membrane very, very loosely. Most people, as they send me their photos, they're not making their buccal flaps as wide as I do generally. I'm still on the wider edge. There is a doctor in India who his is a third wider than mine. He can't get the cheek closed at all, and he doesn't close it, period. But he doesn't get into the fat as much as Tarek does. He's like me, and he'll leave a thin layer of buccal hair just kind of support it, and it just epithelializes right over there without too much contracture. You get contracture when things aren't opposing it, but your cheeks are always moving, so it keeps it open, so it doesn't do that. Okay? Thank you, everybody.
Yeah, thank you, Bob. So we'll move to our last session, which usually you have the dessert by the end of the meeting. So it's our pleasure to have Dr. Abdel Fattah Sada. He's a professor of oral and maxillofacial surgery at Tanta University and a former head of the university, actually. And he's a multi-talented surgeon, administrative manager, and head of the Egyptian oral and maxillofacial surgery. We're gonna have his presentation about the bone surgery for the cleft maxilla. It's our pleasure to have you, Dr. Abdel Fattah, ويعني أنا متشكر جدا على حضورك معنا.
Thank you, Dr. Mamdouh, for inviting me and your very kind words and introduction. Actually, thank you for the Cairo Cleft first, and also for the first symposium maxillofacial surgery in Luxor. And we came to the heart. We left the soft part, and now this is the hard part, is the hard tissue. And usually the maxillofacial surgeons are more fond of playing with the hard tissue. So usually at the end, we see that the bone surgery is in adults or older age is the final touch for correcting the deformities following the cleft. So about 25 to 60% of the patients have a skeletal deformity for the cleft patients. And as we see, how severe the hypoplastic maxilla is seen. So usually we have a problem in the skeleton and in the dental problem. And that's why there is no universal planning for treating all patients the same. We usually individualize our treatment planning through one or more of the following techniques. Of course, the orthognathic surgery is commonly used, but in severe and more or less moderate cases might be impossible or not gratifying results. So we adapt to rapid movement of bone fragment after the osteotomy, therefore relapse usually occurs in these cases. Lefort-1 advancement is not the best technique for treating these patients. It usually ends up with maybe VPI in some cases, especially about 10% when advancement is more than 10 millimeters. So we shift to the distraction osteogenesis. We started with McCarthy in 1992, and by external distractors with some psychological stresses and special care needed with the external devices that rely on intraosseous pins to traumatize or traumatic forces, and also several require adequate dentition for fixation of an intraoral splint and skin scarring. However, we shift to the intraoral one with its better advantages for better patient acceptance, direct adaptation to bone, and also reducing the distance from callus formit and the activating screw, better wound management, but with little or few disadvantages, which is mainly the recurrent infection sometimes is seen, and also you need another surgery to remove the distractor. Preparation of these patients, we have a photographic assessment first, a radiographic assessment, cephalometric assessment, and sometimes we construct 3D models. Intraorally, we should plan for putting our intraoral distractor after Li4-1 osteotomy. And we should keep parallelism for the two distractors so to guarantee the complete advancement of the maxilla. Li4-1 osteotomy. Sometimes we don't put alveolar grafting at the time of distraction, but we leave it to be inserted at the time of re-entry to remove the distractor. So we keep the three segments together in bilateral cases by using an internal bone plate crossing the gap. Intraoral placement of the distractor bilaterally, and then this is the protocol. So through osteotomy, latency period, few days, 5 to 7, activation 1 millimeter per day, and then we can manipulate the callus after complete activation, so we can change the position finally, and then consolidation is longer than usual. We leave it for 6 months, and then at the time of distractor removal, we insert a bone graft. If we need a grafting of the cleft, alveolar cleft, we insert that at that time the bone graft, and then the follow-up. This is also, you can see the callus manipulation here, from here to here, before and after, before also and after, from here to here, also before and after. This is during consolidation. The same for the facial projection is achieved after distracting the maxilla. Before also and after Li4-1 distraction osteogenesis. You can see here the bilateral distractor and the bone plate is in place. Also, in this case, you can see also after Li4-1 osteotomy and maxillary advancement using distraction osteogenesis. Before and after, and also before. You can see how far the convexity is achieved of the facial configuration. This is the dentulus in the anterior. This is a partial denture, but you can see how far the canine is advanced from this to this. Before and after also. It's before and after. Still, we have a chance to have an orthognathic surgery together with intraoral distraction. If it is not adequately advancing the maxilla, you can at the end, at the time of removal of the distractor, you can do a Li4-1 again and advance the maxilla, or even you can re-distract the maxilla. You can close the distractor, open it, close it, and then re-distract your maxilla. A more rigid distraction have been developed also locally here in Egypt for distracting maxilla in adults, which is more potent or more powerful than the conventional one. It was presented at in India at 2007. Also, this is the two distractors which are parallel together. Parallelism should be mandatory. These are two distractors. In 10%, when advancement more than 10 millimeters, they are experience irreversible deteriorated VBI in such patient. 10%, if the advancement is more than 10 millimeters, we found a residual VBI or deterioration of their VBI. So we shift to anterior maxillary osteotomy, keeping the contact between the posterior molars in good relation and avoiding affecting the soft palate. And at the same time, we can increases the size of the maxilla, which is a hypoplastic maxilla. Instead of Li4-1, still it is hypoplastic, but advanced in a proper position. This is the Leo distractor for advancing the anterior maxilla. This is before, after distracting the anterior maxilla by Leo distractor, and this is few years later. You can see also the projection and of the oral cavity, of the upper jaw. You can see here definitely after distracting posterior to the first molar, the achieved increase in the maxilla. You can see here the 3 molars are seen here. And this is the amount of distracted bone in the upper jaw after distracting the maxilla by and doing anterior maxillary osteotomy only. So our protocol here is the same is latency period, activation, elastic traction after callus manipulation, consolidation for 3 to 6 months, and then distractor removal. Anterior maxillary distraction also, you can see before, and this is after, and this is the achieved increase in the size of the hypoplastic maxilla and the advancement. No need, now you can correct the teeth orthodontically without the need for extraction of teeth. For adults with alveolar graft unaddressed, well, this guy have an bilateral alveolar cleft, and the maxilla, the premaxilla is in cross position. You can see the defect here. And then we decide to have premaxillary repositioning, bilateral premaxillary grafting, you can see, and subapical osteotomy of the lower anterior teeth. And here, after grafting and bilateral alveolar cleft grafting, putting a plate to bridge the defect, okay, and this is subapical osteotomy of the man. And 6 months later, you can see here the alveolar cleft grafted, and this is our 2 implants inserted in the grafted alveolus. And here, it's final after prosthetic rehabilitation of this guy, okay? This is 2 implants inserted in the alveolar cleft, and this is the bone plate which is bridging the cleft. In conclusion, the intraoral distraction osteogenesis for 3D, the correction of moderate to severe hypoplastic cleft maxilla achieved successful and stable result with high patient compliance and minimal relapse, overcoming the limitation in both soft and hard tissues with minimal effect on VBI or competencies. Orthognathic surgery still has a place. As complementary maxillary advancement at the time of device removal could be applied, mandibular setback of anterior subapical osteotomies combined with premaxillary advancement provide an acceptable alternative to maxillary distraction osteogenesis in adult patients. Thank you.
شكرا دكتور عبد الفتاح على البرزنتيشن الجميله. يعني طبعا الشغل الاورثوجناسيك هو ميكسد ما بين التجميل والاسنان، وهم حبايب جدا في كل مكان. فانا يعني it is my pleasure. انا هتكلم بقى بالعربي بما ان الناس كلها، في حد هنا اجنبي؟ في حد اجنبي؟ مفيش. Oh, okay. I was asking. I was saying that we have a nice feeling between the orthognathic surgeon and the maxillofacial surgeon from medicine origin. So we've heard the point of view from Dr. Abdel Fattah Sadaqah. Our next presenter is Dr. Muhammad. He's assistant professor of plastic and maxillofacial surgeon in our faculty of medicine. Muhammad and I have been friends since a long time. He was a resident at my department, and he had the chance to go to train in Korea, South Korea, on in a special cleft and craniofacial center. So I encouraged him. Actually, he was asking before for my advice before he went there, and I told him it's a good chance and keep concentrating on the secondary cases. because you are not gonna compete with me in the primary soft tissue arrangement. I don't do any bone surgery except bone grafting. So he listened to the advice actually and returned back to Cairo 4 or 5 years ago, and he's very dedicated to help secondary cleft patients, and he become very eminent in his work, and we're gonna see his point of view from the plastic about the secondary bony correction for cleft patients. It's my honor, and Muhammad was one of my students at one time, and now he's a colleague and part of Nile Cleft Center. He does all of our cases and does a lot of secondary rhinoplasties, and it's really, I'm proud of him, of what he turned to be.
شكرا دكتور ممدوح. It was my honor to be your resident at the time. اشتغلت مع حضرتك حوالي 6 شهور، كانوا 6 شهور محترمين. بس أنا قبل ما أبدأ هيبقى عندي تعليق على دكتور ممدوح وعلى دكتور طارق. دكتور ممدوح قال إن اللايت at the end of the tunnel is switched off، وللأسف إحنا اللي بننوره، تجميل. وإن كان دكتور طارق شايف إن هو أهم واحد في القاعة فده حقيقة، بس هو في الآخر العين ما بيفتكرش غير التجميل. والحقيقة دكتور طارق عمل لي حالات VBI، كنت أنا أعمل لهم لي فورت وحاجات كده، بس العينين في الآخر بيشكروني أنا. فدي الحقيقة. طيب we'll talk today about cleft skeletal correction which procedure for which patient. بشكر دكتور صدقة طبعا اتكلم بإسهاب في الحتة دي، بس أنا هقول إجمالا التوبكس. It's a multidisciplinary team. ده الجريت ايم بتاع اي كليفت بيشنت، ان هو يوصل لنيزل شيب ايديال سيمتريكال، الليب مينيمال سكارينج، الليب الكيوبيك بو، الشيب بتاع الليب كلها. والحقيقه كتير مننا بيقدروا يوصلوا لسيمتريكال نوز، التب مظبوطه، السيمتري مظبوطه، لكن لما نشيل البيز هنلاقي تحتيها ديفورميتيز كتيره، سكار in unfavorable place، الكولوميلا، الشيب بتاع النوستريل، الليب نفسها asymmetrical. وانا حبيت ابدا بالراينو لان هي دي النقطه اللي كل البيشنت they are coming asking for a rhino for the shape. والحقيقه الصوره اللي فاتت ما هي الا the same picture of this house. It's a nice house but the base of the house is destroyed, so the house will come down. As a plastic surgeon in rhinoplasty, we are talking about the tip projection. It's usually the tripod concept in which the lower lateral cartilage and the columella are seated on a stable base with piriform aperture and anterior nasal spine. When we are talking about the secondary deformities in a cleft patient, we'll found first the lip and nose. There is a residual cleft lip and nasal scarring, nasal cartilage distortion, deviated septum, hypertrophied nasal terpenate. When we are talking about the teeth and the occlusion, there is impaired or residual nasal fistulas, cleft dental gap, missing or malformed teeth, dental crowding, etc. When we come to skeletal deformities، وهو ده اللي احنا هنتكلم عليه بالتفصيل، هنلاقيهم بنتكلم على defect or hypoplasia involving the piriform rim, nasal floor and alveolus, maxillary hypoplasia, maxillary canting and asymmetry, compensatory mandibular asymmetry, and mandibular gross disturbance. And this is the severity score. We start from piriform aperture deformity or hypoplasia going down to complete maxillary mandibular distortion. The prevalence of dentoalveolar deformities in normal patient, it's 2.5%. However, in cleft patient, it rise up to 25 or 30%, which is 10 folds more than normal people. When we are looking to those patients from 3 view, front, lateral, and basal view, this is a unilateral cleft patient, and this is bilateral cleft patient. We'll notice that from the lateral view in the unilateral patient, she looks fine, and the basal view and frontal view of bilateral, the patient looks fine. However, the anterior view and basal view of unilateral are not the same, and the lateral view of bilateral also have a problem. Thus, one size fits all store is not applied in these deformities. When we are talking about deformities, we have intrinsic deformities and surgical heterogenesis or secondary deformities. About the intrinsic deformity, the whole area is deformed. The lower lateral cartilages, the shape, the piriform aperture, the anterior nasal spine and deviated septum, the relation of the lesser segment and major segment in unilateral and premaxilla in bilateral cases, all is deformed and distorted. Also, for us as a plastic surgeon, the lower lateral cartilage also severely deformed. All these deformities lead to skeletal deformities and improper nasal shape. The fourth dimension is one of the major factors affecting head and neck growth. دكتور ممدوح always talking about الجروس، وكل لما اكلمه على عيان يقول لي اصبر، ما تعملوش حاجه، اصبر، سيب العيان في حاله، سيب العيان لما يكبر هيتحسن. And it always like this. The shape of the skull changed dramatically from newborn, 5 years, 14, adults, and elderly. It always changed. Thus, we have to consider also always the fourth dimension, with the time. For this, if we look for this girl, she have good occlusion. The lip is very nice. There is minor deformities in the nose. Another patient with bilateral cleft lip and palate. If we look for the patient from the profile is good. She have adequate mid-face projection. The mandible is okay. And here also slight deformity in the nose. Scars is good. But if we come closer and we start to look, we'll find there is class 3 malocclusion. So this is a graph showing the growth of the cranial vault, the maxilla, and the mandible from birth till 20 years. We found that the skull growth is the first to end, while the mandibular growth is the last to end. Our girl is 7 years old, so when we are looking for this graph, when we plotted in this graph, we'll find that the skull is almost in the plateau phase. The maxilla is midway, while the mandible is far away. Another nice paper had been published in 1991. It's comparing the position of anterior nasal spine in normal patient, unilateral cleft and bilateral cleft. If we're looking here and put the age of this girl, so if you put her age, it's just almost 7 years, we'll find that the position of anterior nasal spine in bilateral cleft patient and non-cleft patient is almost the same. While we are going older, we'll find that the anterior nasal spine is decreased and the patient will complain of class 3 significantly. So this girl is not normal. And if we judge this patient at this time, of course, it's not a good choice. We have to let her grow up and decide what is her problem. Of course, orthodontic can start work to decrease the degree of malocclusion. However, I expect this patient to have class 3 malocclusion. When we are talking about surgical iatrogenesis, which is trauma caused by surgeon during the repair, early hard palate closure, palatal flap with extensive denuded bone, the point that was Dr. Mamdouh talking with Professor Chang, the dissection in the maxillary area, the extensive use of marine flap, extensive orofacial muscle dissection, extent of trauma and scarring, which we are talking about single stage or multiple stage. Of course, multiple stage repair decrease the trauma, the one that Dr. Mann had described, to close the palate first and then close anterior palate. Delayed bone grafting also affect this. Non-utilization of pre-surgical orthopedics or soft tissue molding also affect the bone growth. So what could be the skeletal deformities in teenagers? Actually, I like to group them in 3 groups: alveolar cleft or nasoalveolar fistulas, paranasal area, which is hypoplastic piriform rim, and finally maxillary hypoplasia and plus or minus mandibular involvement. And I guess Dr. Sadaqa had told us a lot about this. I will go simply in each one of them. The alveolar grafting, we are talking about secondary is a standard at the age of 7 to 9 years. However, some surgeons prefer to do primary bone grafting. The late bone grafting, I encountered a lot of patients come at the age of 16, 17. Of course, the result at this age is not that good as 7 or to 9 years. However, nowadays we add some PRP, platelet-rich plasma, to the bone graft. It improves a lot the take of the bone. Also, we can talk about alveolar destruction. Dr. Sada had talked about alveolar destruction. When we use it, especially the transverse, wide alveolar cleft, large nasolabial and oronasal fistula, unhealthy, severely scarred gingiva, history of repeated unsuccessful bone grafting, maxilla with severe vertical deficiency. So when we come to the second part, it's the paranasal area or paranasal hypoplasia. This patient have a very good occlusion. However, the piriform area is deficient. This patient can benefit from paranasal augmentation, which we could do it with autologous bone or autologous cartilage or synthetic material like Medpor. So when we do paranasal augmentation, normal or almost normal upper arch, occlusion is perfect, no or minimal maxillary hypoplasia, relative lower midface concavity, accepted lip support. At that time, the paranasal augmentation would be a great additive to this patient. And this is a comp beam and CT scan of a patient. We can notice empty paranasal area. Actually, I like to use costal cartilage. In rhinoplasty, we use it extensively, so we can do at the same time of rhinoplasty or a separate stage and then banking the cartilage. We do the paranasal augmentation with the cartilage. We can fix it with mini screws. This is a patient with bilateral asymmetrical paranasal augmentation. We can notice here from the views there is empty piriform aperture. This is a picture pre and this is a picture post-op. We can notice the improvement of the alar base. Of course, you need rhinoplasty. And that's why we switch on the light by the end of the tunnel. Another patient with unilateral and then rhinoplasty. Another patient with lip deformity, nasal deformity, and also deficient piriform aperture. We do paranasal augmentation and rhinoplasty. Finally, the maxillary hypoplasia plus or minus mandibular involvement. This patient with bilateral cleft lip palate, the patient come complaining of severe maxillary hypoplasia. For those patients, we can think about orthognathic surgery, either maxillary surgery in the form of Lee-Fort-1, either orthognathics or by distractors or double jaw. So when to choose orthognathic surgery in severely deformed or hypoplastic upper arch, severe maxillary hypoplasia, either EP, vertical, transverse, patient with glass remal occlusion, poor lip support, maxillary canting or asymmetry, and compensatory mandibular asymmetry, and mandibular gross disturbance. This patient with severe maxillary hypoplasia, of course, he have alveolar defect. Of course, we use cephalogram and cephalometric analysis using the SNA, SNB. This is the patient. The teeth, orthodontics are applied. We use 3D models nowadays for the site of osteotomy and the pre-bending of the plates. And this is how we could do it. It can be done with alveolar bone grafting at the same time. And this is patient pre-operative and 2 weeks post-operative after Lee-Fort-1 advancement with 7 millimeter advancement. Another patient with 9 millimeter advancement and rhinoplasty post-operative. ودي واحدة من العينين اللي دكتور طارق عملها والعينة بتشكرنا أنا. Another patient with lip deformity, nasal deformity, and maxillary hypoplasia, advancement of 6 millimeter. Start with a BAY flap for correction of lip, and then Lee-Fort-1, and then rhinoplasty, and we can notice the improvement. Of course, it's just 2 weeks post-operatively, we still have some stitches here. Unfortunately, don't have long-term follow-up for this patient. The patient with severe maxillary hypoplasia, advancement of 11 millimeters. And unlike what Dr. Iman said or Dr. Sadaqa said, it's not usually we have a problem in the PVI following advancement. This study had been published in 2004. They report some improvement in some scores of the VBI score. We can notice that they may translate into improvement in certain aspect of speech disorder, وهيجي على رأسهم الهايبر نزاليتي، وكمان الحاجات اللي ليها علاقة بالانتيريور دنتيشن نزلت من 64% ل 47%، لأن العيان بيقدر يارتيكوليت. العيان ده هو مفيش صوت.
مالك يوم الدين، إياك نعبد وإياك نستعين، اهدنا الصراط المستقيم، صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
This was 1 year post-operative and the patient don't have VPI at all. I recommend any patient coming with severe maxillary hypoplasia just to do the Leefort one, and we can assess the speech 1 year post-operatively. I noticed almost 90% of patients, they don't complain of any VPI, even though we advanced like 11 millimeters. Another patient with almost 10 millimeters don't have VPI. The profile improved a lot. Of course, we can use the distractors as Professor told us about the internal and external RED device. We can use it, especially in cases with severe maxillary hypoplasia. وهنا لازم اشكر الدكتور ممدوح، هو اللي اتبرع لنا بجهاز الريد ده للعيانين دول ان احنا نعملهم فور فري. شكرا دكتور ممدوح. طيب هنيجي بقى كومباريزون ما بين الكليفت ديستراكشن والاورثوجناتكس. طبعا كله هيبقى ميال ناحيه الديستراكشن is more stable with lesser relapse, and most of the study report this. 2 minutes please. So to sum up, which procedure for which patient? When I have a patient with skeletal deformities, I will divide them into camouflage procedures or orthodontic or orthognatics procedures. The camouflage procedures in form of paranasal augmentation only, alveolar bone grafting and paranasal augmentation. I usually do it in the same setting. I usually do a graft. I use the costal cartilage for paranasal area and the bone for alveolar grafting. I noticed a good take of this bone. Alveolar distraction, the paranasal augmentation. And the other is orthognatic surgery, either single jaw, the maxilla, or double jaw. Smile can change everything, and plastic surgeon is the last surgeon will come in touch with the patient, so the patient will always favorable for his doing. شكرا.
بنشكر محمد، وبما انه اقليه معانا هنا فاحنا هنستناه بره القاعه يعني.
مش انت اللي قلت السويتش اللايت سويتش اوف؟
ايوه، لا سويتش اوف ده لينا احنا لحياتنا احنا، مش ليك انت، مش ان العيان خلص خلاص. احنا finally will finish our presentations today, and this heavy schedule by our ENT surgeon. He's not a cleft surgeon now, he's an ENT surgeon. He's gonna give us a very short presentation about the ENT care for the cleft patients. I think that it's not part of our practice, but it's part of our job. You have to know when or at what time you should refer the patient for the ENT surgeon, not for speech, but for the ears only. That's it. Ear and nose. Okay.
Can I ask everybody in the attendees? They have a cleft. They do cleft surgery. All of you do cleft surgery. Not all of you. Which one of you has incorporated the ENT doctor in his program or in his hospital? Only 2, 3, 4. Okay. So this talk is to tell you, is the ENT doctor an important part of the multidisciplinary team of the cleft care or not. So the first talk of my talks was the most important talk. This is the second most important talk. I'm talking especially for plastic surgeons, Dr. Mohammed. This is the second most important talk. Okay? The first one was the first most important talk, after your talk, of course. So in a comprehensive cleft care team, as you can see, we have the orthodontic, we have the nutrition, of course, the plastic surgeon, the speech pathologist, and you should have the ENT doctor part of your team. Everybody thinks that you need the ENT doctor just for the ear problems, but I want to tell you it's much more than this. We are glad to tell that our team is the first team worldwide to incorporate ENT services in the comprehensive care for the cleft with the Smile Train. Why do you need an ENT surgeon in your cleft team? First, we talked about cleft, palate, and speech. And if you have an ENT doctor who is dedicated for assessment or managing patients with the speech problems, he will be very beneficial for your team for assessing or managing the velopharyngeal insufficiency. Second, the cleft, palate, and hearing. As we all know, the ear consists of three parts: the external auditory canal, the tympanic membrane, middle ear, and inner ear, and of course the Eustachian tube. This is an endoscopic view of the Eustachian tube because we all hear about the Eustachian tube. We don't know where the Eustachian tube is. This is where the Eustachian tube is. If you do nasal endoscopy, this is the orifice of the Eustachian tube in the nasopharynx. And the palatal muscles act on the Eustachian tube. So you are performing surgery on the palate, the Eustachian tube is going to be affected. What does the palatal muscles do? The tensor vello palatini and the levator palatini, they act together. The tensor is the action, is the opener of the Eustachian tube, while the levator vello palatini acts to help the tensor muscle, so that both of them will act like a sphincter and they open the Eustachian tube. Every one of us, the Eustachian tube is closed at rest. It opens when you yawn or when you swallow. So at least 2 or 3 times every minute, you're going to swallow and your Eustachian tube is going to be open and it pushes air inside the middle ear. So in an infant or a child, the Eustachian tube is narrower, shorter, and more horizontal. In an adult, the Eustachian tube is longer, thinner, and less and more vertical. And these are the differences. So a child is more prone for having middle ear infections, for having Eustachian tube problems because of his anatomy. And when the Eustachian tube doesn't perform its function, secretions, first, air will not be available in the middle ear, and then secretions will start to build up behind the tympanic membrane in the middle ear, and we will have the most common problem that is faced with the children with cleft, which is secretory otitis media. This is the normal tympanic membrane. This is the tympanic membrane of a child with secretory otitis media. You will notice the yellowish tinge behind the tympanic membrane and the air bubbles. This is how the secretory otitis media will look like. How do we test for the Eustachian tube function? Very simple device called the tympanometer. This device has a tip which can be inserted inside the ear of the child. This tip incorporates inside of it few tubes that pump air in the external auditory canal and test the mobility of the tympanic membrane, and it tests also the middle ear pressure. How we do the test? Very simple. The ear plug connected to the device, we put it inside the ear of the child. It's not painful. It doesn't cause any harm to the child. And then we will get the device will give us a graph. This graph you have three types, type A, B, and C. Type A is the normal middle ear pressure. Type B is the secretomotor media. This is what we see in the children with cleft. And type C means Eustachian tube dysfunction. So what happens in the Eustachian tube of a child with cleft palate? This is the normal, this is the cleft child. There is abnormal curvature of the Eustachian tube. There is hypoplasia of the lateral cartilage that forms the Eustachian tube, and there is abnormal insertion of the tensor veli palatini and the levator veli palatini muscles. All of these will end up by having a deformed Eustachian tube and a bad middle ear function. So what's the result of this? This will end by having secretomotor media or recurrent attacks of acute superior otitis media, and this will end up by conductive hearing loss. And we all know that a child with cleft should have proper hearing, because if he had conductive hearing loss, he will have delayed speech, and delayed speech development will affect his speech. We want to examine this child for velopharyngeal insufficiency. You cannot examine child for velopharyngeal insufficiency if he's already delayed. And if we move on the spectrum, you can have a tympanic membrane perforation, adhesive otitis media, or even cholesteatoma. These are the more aggressive forms of complications that can happen for secretomotor media. How do we treat this? We treat it by insertion of ventilation tubes. We have two types of ventilation tubes, the grommet and the T-tube. This short video will show us how do we insert the grommet tube. The tympanic membrane, we just do a small incision in the anterior inferior part of the tympanic membrane. Then you will suck all the secretions that's behind the tympanic membrane that is causing the conductive hearing loss. Sometimes it's very thick that even the suction cannot suck it out. So sometimes we don't call it secretomotor media, we call it glue ear, because the secretions behind the tympanic membrane are very thick like a glue. And then we will insert the ventilation tube. The ventilation tube here acts as a substitute for the function of the Eustachian tube. Air will come from the external ear canal instead of coming through the Eustachian tube. And this is how we perform the surgery for the T-tube. The grommet tube is the temporary tube. It lasts in the ear for about 6 months, 1 year on the maximum. The T-tube is we call it a long-lasting tube because it stays in the eardrum for years. Of course, it's called T-tube because it looks like the letter T. This is how we insert it in the tympanic membrane. Okay. Then, when are we going to perform the surgery, and what type of tube are we going to use? We perform the surgery. It's controversial, but our plan in our protocol is that we do otoscopic examination and tympanometry are also usually around the age of 2 years. And then if we find secretomotor media persistent and it's not responding to medical treatment, we will put T-tubes. We stopped doing the grommets because it fell down and the secretomotor media will come again, and then we have to put the tubes again. So we usually use the T-tubes. Sometimes your child a child with a cleft can have other congenital anomalies. He can have sensorineural hearing loss. We send the patient for ABR, and if they have sensorineural hearing loss, we can give them hearing aids. So we talked about the ENT doctor can help you with speech. The ENT doctor can help you with hearing. Then the ENT doctor can help you with the adenoids. And this is a very important topic. The adenoids are the aggregation of the lymphoid tissue that's found in the upper part of the nasopharynx. And if we do nasoendoscopy for children having clefts, this is what we can see. This is the adenoid tissue, and this is the soft palate. During speech, there is adenoido-vello-adenoidal contact. So the soft palate does not actually, in a child, does not touch the posterior pharyngeal wall, it touches the adenoid. So the adenoid tissue is very important for children with cleft. So what happens if you have a child who looks like this? The adenoid is important for speech, but the adenoid is closing the quena, it's closing the posterior part of his nose, and he cannot breathe. So how would you do this type of balance? We want him to breathe well, but we don't want to affect his speech. This is the endoscopic examination of a child with cleft, and his adenoid is obstructing the posterior quena. Then what to do? We have to do adenoidectomy to improve his breathing. But the conventional type of adenoidectomy that we do with the adenoid curette, like this time, we just insert the adenoid curette behind the soft palate, and then you curette the adenoid tissue and get it out. This type of procedure will remove all of the adenoid tissue. And if you remove all the adenoid tissue, your patient will have more VBI. And you don't want this to happen. So what we do is what we call superior adenoidectomy. You just remove the upper part of the adenoid, which is obstructing the nose, and you leave the inferior part of the adenoid for velopharyngeal contact. You can do this using the suction cautery, or you can do it by decuplation. The best technique is using decuplation. This is how we do it. This is the adenoid tissue obstructing the quena. We want to remove this upper part. We want to leave the inferior part. So decuplation is a very good instrument and tool in doing this. It does the procedure almost in a bloodless way, and you have under control, you can remove the tissue that you want from the upper part of the adenoid, and you leave the inferior part of the adenoid tissue so that you won't affect the speech of the child. This is called superior adenoidectomy. We leave this part, we remove only the upper part. And then, what about the tonsils? Do patients with cleft, they don't have tonsil infections? Actually, they do. So what if you have a patient with chronic tonsillitis? Also, this is a cleft patient with huge tonsils. Not only there are recurrent infections, but this patient has obstructive sleep apnea. How are you going to deal with this patient? Sometimes the tonsils not only do this, but the tonsils can share in the velopharyngeal sphincter. This child, this is the soft palate, and this is actually his adenoids. The adenoid is intervening between his soft palate and the posterior pharyngeal wall. It's sharing in the velopharyngeal valve. How are you going to deal with this type of tonsils? Then, all what you need is to do tonsillectomy, but not every regular ENT surgeon, I do not recommend the regular ENT surgeon to perform this procedure, because you have to do a very meticulous tonsillectomy and preserve the palatopharyngeus and the palatoglossus, because actually in the regular tonsillectomy procedures, you can get VBI. So if you have a child who's prone to have a VBI, doing the procedure with a regular ENT surgeon, he may end up by having VBI. So it has to be done very meticulously with someone who knows about cleft surgery. Then what about cleft palate and speech disorder breathing? A cleft child with Pierre-Robin syndrome or any other syndrome, he can have obstructive sleep apnea and snoring. And how to deal with these kids? You can do tonsillectomy, partial adenoidectomy, CPAP, mandible distraction by the plastic surgeons, or even tracheostomy. Then lastly, what about cleft palate and voice? Children with cleft palate can have voice problems. They have laryngeal hyperfunction. Sometimes because of the velopharyngeal insufficiency, they attempt to speak in a louder voice, and it ends up by having vocal nodules. And on the other side, they can have very soft voice, and this is what we call the soft voice syndrome. If you have a child with cleft and he has bilateral vocal fold nodules, doing surgery at this age needs attention. It needs meticulous work of microlaryngeal surgery. This one of the patients that we did microlaryngeal surgery for him, removing very small nodules from his vocal folds. And of course, you can send the patient afterwards for voice therapy. So at the end, the ENT surgeon is part of the multidisciplinary team, and he's the second most important person after the plastic surgeon. Thank you.